Ma'am,
So we have 1 minute left. Already 3:59.
yeah, we have Suma ma'am joining, who have joined us. I pulled her from the delegate to faculty.
Okay.
Shirisha ma'am is joining us, and Sudha Padmashri ma'am is also joining in 5 minutes, in 2 minutes.
Okay.
Can you resend Sudha Padmashri ma'am the faculty link?
That is what I'm doing for
Great.
those doctors who are like finding challenge. I'll reshare it.
Yeah. Dr. Suma Varsha ma'am, welcome to the panel. Kedar sir, welcome.
Hello.
So first panel we are there. Everybody is there. So 2 minutes for Shiresha ma'am and the Sudha Padmashri ma'am to join, and we can then start.
I've shared with Dr. Sudha the link again. Dr. Anita has joined. Dr. Sudha. Dr. Sudha has also joined, sir. Doctor, unmute yourself. You're muted.
Yeah, I am Dr. Sudha Padmasree, not Sudha Prashad. I'm Dr. Sudha Padmashri.
Hello, ma'am.
Okay,
How are you?
Hello.
What happened, Komal?
Dr. Sudha Prasad, it's written. I don't know why.
Yeah, it's written Dr. Sudha Prasad. That's why I got confused.
No, we can rename it.
I'll rename it.
Rename it, no?
Yeah. So we are waiting for only Shirisha ma'am to join in.
I will again send the link to Dr.
Shirisha Rani ma'am has joined in. I'm promoting her to panelist. She's there. Okay, now she's there with us. Can you see her?
No, sir. No, as of now.
Excuse me. I promoted her.
Yes, now I can see her.
There now. She's there. Kedar sir, you're there?
अमित बुलाए और मैं ना आऊं.
अरे नहीं sir. How are you, sir? So we have Shirisha Rani ma'am with us. We have Sudha Padmashri ma'am with us, and all the faculties are also there.
Okay.
And it is about time.
Sure.
So Komal, should we?
Komal, you will introduce the panelist.
I can do that.
Yeah. Give me a pen and a paper. I need to write the name of the panelist. Okay. All the stalwarts.
Yes.
South, I don't have to worry normally. They are well read. Very well read people.
Absolutely.
They will take my exam now. See?
So Komal?
So, okay, sir, with your permission, I will start the program. So
Yeah.
I'll mute all before just starting the webinar. So in the process, everyone will get muted. So if you want to unmute, you can unmute yourself. So yes. So a very warm welcome and thank you everyone for joining this webinar today of AP chapter of ISAR. My name is Komal Kanodia, working as a brand manager with IVA, a division of MCure. MCure is pioneer in the field of gynecology and IVF. And we at IVA are on a mission of nurturing 28 days of ovarian cycle. And hence all our webinars are called as Programming 28 Webinars. I would like to thank Dr. Kedar Gandla, Central ISAR, Dr. Prakash Trivedi, and Dr. Sudha Padmashri, Dr. Shirisha Rani for giving us this opportunity of hosting this webinar. So we are doing a series of state ISAR webinars with Central ISAR Association, and this is our, I believe, 5th or 6th session with the state chapter of ISAR. And we will be continuing this session, and already we have conducted 250 plus webinar when it comes to Programming 28. And at the same time, Materna is our quality brand, is epitome of quality and precision. Today we have Dr. Amit Borse with us, who is heading the PMT and medical marketing of IVA. So Dr. Amit, would you like to say a few words before starting the webinar?
Yeah, thank you so much, Komal. So firstly, thank you to Central ISAR and AP ISAR, and we are very thankful that we are a part of this academic initiative, a movement, and we have been thoroughly happy to get supported by ISAR. Last year, we did 12 webinars for ISAR, and this is our 5th webinar, and we'll be continuing it further as well. So we are just a call away, and MCure will always be available there for all the doctors. You can see our 100 plus webinars are loaded on IVF Virtual Academy. It is a YouTube channel, and do let us know for any other support. Thank you, Komal, and let us push forward with the webinar.
Sure, sir. So I'll just share the screen.
So before we go forward, may I request Dr. Sudha Padmashri ma'am, chairperson for APSR, and Shirisha ma'am, secretary for APSR, to speak a few words, and we can hand over the session to Kedar sir then. Right, sir?
Very good afternoon to all of you and a warm welcome. On behalf of the Central ISAR and the AP ISAR and the MCure Pharma, I would like to extend my warm welcome to all the panelists, to all the delegates, to the moderators, and especially to our chief guest today, Dr. Kedar. He's the center of attraction of any discussion or any panel discussion. He makes the panel so lively. And another special invitation to Dr. Sulba. She is also an extraordinary, intelligent old lady. And with this, we go off to our topics. The first, I'll ask Sirisha to say a few words, and then we start our topics. Probably Sirisha is busy, so on behalf, Sirisha, are you there?
Yeah, ma'am is there. So, ma'am, you'll have to unmute yourself.
Oh, probably she's traveling somewhere, I think so.
Yes,
Sirisha,
yes, she's
can you
in a
hear?
car.
Yeah. So, okay, we can write it, start with our topic. Today's topic, the first panel is what a very interesting panel. We have pregnancy management following an ART, and then how to manage it. We have got young team, young and very upcoming IVF specialists. Of course, they're also senior, but we have very, very enthusiastic panelists and an extraordinary moderator, Dr. Kedar. He will, I hope, let's start it now.
So before just starting the webinar, would give a intro of Dr. Sudha Padmasree. So Dr. Sudha Padmasree presently heads Padmasree IVF Center as a core fertility specialist and trained in advanced gynec laparoscopy surgery. She is having a lot of leadership qualities, organizing secretary for the 4th annual CME at Visakhapatnam, secretary of FOXC 2009 and 10, joint organizing secretary for Andhra Pradesh State Conference, presently owns Padmasree Hospital, a 100-bedded hospital at Visakhapatnam. She also has a lot of academic activities she has taken, presented various papers in national and international conferences, and invited as faculties for various AIOCG podium and AOCOG, ASICON held at Ahmedabad. She is also having a passion for infertility and laparoscopic surgery and constantly updates by participating in national and international conferences. A very warm welcome, Dr. Sudha.
Thank you.
So now I would like to introduce Dr. Sirisha Rani. She is an MBBS from Andhra Medical College, Visakhapatnam, DNB from National Board of Examination, Diploma in Reproductive Medicine and Embryology from Kiel School of Reproductive Medicine, Germany. She is Director of Vizag IVF Center at Visakhapatnam, Director of Lancet Laparoscopy Center at Visakhapatnam, working in the field of infertility from the last 16 years. Published an article on CASA-derived human sperm abnormalities, Executive Council member of SAR AP chapter, Secretary of AP Nursing Home and Hospital Association, elected member, Obs and Gynec Society Visakhapatnam, Treasurer of IMA, Secretary AP ISAR 2021-2023, Joint Secretary of Obs and Gynec Society of Visakhapatnam, and worked as a Joint Organizing Secretary for UA FOXY 2021. A very warm welcome, Dr. Sirisha. Then we have none other than Dr. Kedar Gandle. We all know Dr. Kedar Gandla. He don't need any introduction, but still would like to give a brief introduction about Dr. Kedar Gandla. He is MD Gynecology, practicing more than 25 years at Ankur Fertility Center, Dadar, Mumbai. Currently Honorable Secretary of ISAR, and over 25 international publication and national publication in scientific journals. His infertility management not only includes medical management and ART procedure, but also
Komal, thanks.
Okay, doctor. Will not take much of the time. Then I'll go for our panelist introduction. We have onboarded with us Dr. Sri Harsha Ravuri. She is now presently working as a clinical director, Birth Health Fertility Center, Guntur. And a very warm welcome, Dr. Sri Harsha. Then we have Dr. Suma Varsha with us, MBBS, MS, DNB, Chief Consultant at 49 Hospital, Vijayawada, former consultant at 49 Hyderabad, and ex-assistant officer at SVIMS Tirupati. A very warm welcome, Dr. Suma. Then we have Dr. V. Sarada with us. She is trained in reproductive medicine at various centers and presently consultant at Rohini IVF Center, Amalapuram. A very warm welcome, Dr. V. Sarada. Then we have Dr. Sukriti with us. Dr. Sukriti is a consultant in reproductive medicine at Anu Mai Baby Hospital, Vijayawada, MBBS and MS from NTR University. A very warm welcome, Dr. Sukriti. Then we have Dr. Swapna with us. Dr. Swapna right now working as a consultant at Komali Fertility Center, Guntur, Udyanand Fertility Center, Nandyal. A very warm welcome, Dr. Swapna. That's it, doctor. So I have introduced all the panelists, and now I'll hand over the dice to you.
Okay, so we start with the presentation. Can you see the screen?
Yes, sir.
Can you
You'll
see
have
the PowerPoint presentation?
You'll have to double click. We are on this folder.
Okay, 1 minute. Huh? I need to open the screen. Okay, can you see the screen now?
Absolutely, sir.
Okay.
Yes.
So thank you, MQR Pharma. Thank you, Amit. Thank you, Komal. Thank you, Dr. Sudha and Dr. Shrisha. Okay, without wasting any time, we will start with the panel discussion. So this is what everybody wants. This is what our patients expect from us. Okay, even though she is 90 kilos, she will expect to become pregnant at first shot and have a pregnancy outcome like this lady. Okay, that's how the ART starts. This I want you to hear very clearly. Listen to this, read it. Do I believe this? 100%. 100% I believe this. Okay. The obstetric science, if you see, cesarean section was first performed by a the one who cuts the meat, because for his wife she was obstructed labor, and that's how the science could develop. Take the history of ICSI. He wanted to inject the sperm subzonally, but by chance it went inside and ICSI was found. So we know that there are several obstetrics and perinatal complications, majority related to the multiple pregnancy. Even singleton pregnancies are associated with increased risk of complication. Can Harsha tell me some of these reasons with singleton pregnancies associated with having a pregnancy complication? Harsha, please.
I would say most common cause could be the age of the mother or the parents. The next would be the manipulation which we do in the laboratory,
Excellent, Harsha. Excellent. Excellent. Go on.
followed by the medical conditions which are associated with their subfertility or infertility.
Excellent.
And other things would be obviously the multifetal gestations, which are more common with our iatrogenic multiple pregnancies, which I mean, and the
I understood. So basically everybody is understood. We intervene, correct? And that could have been the cause of this. Can you give an example of this? Fast. Anybody can take it. Sukriti. Sukriti. Think about it. Think about one intervention which has created a problem now. We were not doing that. Now we are doing it.
Previously, people used to do multiple embryos transfer. Now we are coming down to single embryo transfers, and mostly we are restricting the number of embryos.
That's science. That's science. I'm talking about an intervention.
Astrocyst biopsy, sir, which is causing epigenetic change, sometimes which might cause epigenetic changes in the embryos.
Okay, you went little ahead. I would say simple. FET versus fresh. FET is resulting into larger babies, more incidence of preeclampsia. So luteal phase, we know that the iatrogenic luteal phase, we need to give progesterone supplementation. 1 minute, and we need to continue till the placenta 8 to 12 weeks. Okay. So first trimester bleeding. Okay. Now in 20% in spontaneous pregnancy, which can be up to 30%. So Suma,
Yes.
can you tell me the most commonest cause of first trimester bleeding in ART pregnancies?
So first thing, it could be just a simple implantation bleeding.
No, madam. First trimester is already started.
Okay.
So once beta acids come positive, we are
It
going
could
on.
be a vanishing twin or a vanishing,
Excellent, excellent.
or it could be because of multiple embryo transfer. I mean, or many patients are given low molecular weight heparin and aspirin. So that could be one reason. And we give them on, we put them on high estrogen doses. That could be one more cause.
Suma,
The chromosomal.
then no, Sarada. Any other things? Very common things. You all are going too fast.
Chromosomal abnormalities could be one of the main reasons, sir.
30% risk of miscarriage in the IVF pregnancy.
Yes, Swapna is hitting the nail. Swapna. Okay, so abortions. What else? Sukruti. Am I taking the names correctly? No, Sukruti.
Sukirti, sir.
Sukirti. Huh?
Yes, sir.
Sukirti. Anything else?
Sir, any unhealthy embryos like anembryonic pregnancies.
अरे वो abortion में आ गया. Go ahead. Think what they say. Think out of the box. What else? Why there could be a pregnancy bleeding in the first trimester? You did 2 beta HCGs. And there is a,
Usually
yes,
placenta.
ectopic. And something more than that?
Heterotopic.
Yes, good. Okay. So we will discuss all these 4 points now. Okay. So what we do, serial beta HCG to rule out biochemical or ectopic pregnancy, ultrasound to location of the number, viability and presence of subchorionic hematoma. Correct? Am I going correct? Well, you can also ask me questions. There is no this thing. It's a panel discussion. Everybody has to understand we are discussing with each other. Okay. Now, spontaneous pregnancies, there is increased loss of natural as compared to natural pregnancy. Okay. On serial ultrasound, the diagnosis of very early pregnancy conceived by IVF, right? So all those biochemical pregnancies are also included. Okay. Tell me what are the causes for spontaneous abortions? Sukirti.
So it could be because of any embryonic causes, or it could be somewhere like medications.
Mhm. Okay.
If the
Abortion causes. Anybody else wants to take it? Harsha?
Sir, it could be either due to embryonic or maternal or the uterine causes. Embryonic causes, as I've already discussed, the chromosomal anomalies in the first trimester would be the most common cause, followed by the other conditions like uterine malformations, infections, chronic endometritis, or other infections like endometrial tuberculosis. And maternal conditions like antiphospholipid antibody syndrome also could be one of the few causes for the abortions. And sometimes the multifetal pregnancies where one twin spontaneously actually miscarries or aborts. Yeah.
So this is the one which I was talking about. With singleton, it's up to 25%. With twins, it's 35%. Vanishing twins or multiple twins pregnancy where it can lead to bleeding. Previous losses, okay, you have done for previous loss. Advanced maternal age, low ovarian reserve, OAT, higher with the frozen embryos as compared to fresh embryos. See, this is what I was telling you. This is thinking out of the box. Okay, subchorionic hematoma management. Swapna. Start with the.
First, we will see what all the medication she's on. If she's on aspirin or low molecular weight heparin, I would like to stop them aspirin and heparin for 48 hours. And if she's on vaginal sustain alone, or what is the mode of progesterone she's getting, I will look into. If she's only on vaginal micronized progesterone, I would like to put her on some other added on because some suboptimal adherence to the vaginal route might be there. So I will add on injectables or oral route of progesterone as well.
Okay. Any particular oral progesterone would you like to add?
Dydrogesterone, synthetic progesterone, I would like to add,
Okay.
sir, because of its immunomodulatory.
What is the dose?
10 mg TID I'll give, sir.
Anybody other than this dose, do you know? Harsha?
It's 40 milligrams stat dose followed by 20 milligrams twice, 12 hourly, and probably it could be continued till the bleeding gets controlled, followed by 10 milligrams TID, the basic dose.
Anything else, Swapna? Go back to your Swapna.
Threatened miscarriage, so we would like to follow it up, sir. Threatened miscarriage also can have subchorionic hematoma.
Any USG parameters?
So what is the hematoma size we'll measure in the first scan?
Okay.
In the serial scans, we follow the size of the hematoma, whether it is getting absorbed or is it increasing in size?
No. You saw first time and there is a calculation.
Yes.
Okay, Suma, would you like to tell me that if the hematoma is this much percentage, likely to be not bothersome, but if it's more than this, well, there is a chance.
If it is 50% of the size of the sac and more, there's more chances of an abortion.
Is it 50%? Swapna?
2/3.
Harsha?
More than 2/3
Yeah,
of the
more than 50% or 2/3. I agree with both.
Two-thirds. Chalo, good. Okay, so that we saw. Okay, then look. 2 o'clock in the night, she calls you. I went to the toilet. I saw a small dot, microscopic dot. Why people take IVF? No, because they don't want phone calls in the night. Now what she should do? Sukirti.
So first of all, I'll ask her not to panic, sir. And then.
But you are not available.
Sir?
You are not available.
I would like to talk with the patient, sir.
How? 2 o'clock in the night, you are IVF consultant. You are the queen of the queen. You're not supposed to be disturbed. And especially the South, I speak to the secretary to speak to the boss. And she talks to me in her language only. And I'm not going to give you the phone. Madam is in the big OPD. Simple thing we can do, a simple thing. When the beta HCG comes, they come happily to you. You do something, which I do.
Repeat beta HCG.
We try to do 2 o'clock, Sudha. How?
No.
2 o'clock, you tell me what to do. Reassurance is at 2 o'clock in the night. She will go to somebody else, and that doctor will give her Duodola. Isn't it? You have not seen? You have seen? Swapna.
For
See?
me, I don't have that.
Scratch. What can you give her?
Nexa.
Tranexamic acid.
Yes, but when? Prophylactically. So we write on the paper, if you get bleeding PV, take this tablet, 1 tablet 3 times a day. Then in the morning, you call me and then I'll attend to you. You understand? And with this, I tell them there's a 30% chance that you will have bleeding because my patients are on aspirin. Okay, my favorite flavor of the month. Bed rest. Sarada. Sarada? Is she there? There you are, mute. Sarada. Mute. Unmute yourself.
Am I audible?
Yeah, now you are audible. Tell me.
Yes.
Bed rest, how many
Bed
days
rest.
do you give? How many days do you give?
Initially, I'll ask her for absolute bed rest for
For how
at
many
least
days?
till her spotting is completely not seen. She's not bleeding anymore. Till then, I'll ask her to take bed rest. Once the spotting has decreased, then I'll ask her, you can just move around for your daily routine work. And I take up serial scans again, check for whether the sac is intact and see, continue her progesterone therapy and see that she's continuing all her drugs.
Madam, she is a CEO in a company and she has to go back to the work. She's working from home. She wants to know, can she sit in this place for 2 hours or she has to, like complete bed rest and lie down and do everything on the bed? What is it?
Then I have to check her ultrasound and see whether the retroplacental subchorionic hematoma is increasing
there.
in size.
Subchorionic hematoma is there. Then what you do?
Even if it is there, actually, and if she's not spotting anymore, I can ask her to take rest for about 1 week to 2 weeks, and then she can get back to her work.
Okay.
Slowly, and if the work is not tedious.
Hold on. Now we're going to take a vote of, by raising the hand. We'll start with Sukirti. How many days are bed rest?
Sir, I usually don't advise for bed rest, sir, because it is not going to change the outcome anyhow. So I would just like to ask, first of all, talk with the patient, reassure her, then do, check all the medicines what she's taking. And
No, don't go there. Bed rest pe chicken ho. Stick
sir.
on to the bed rest. No bed rest.
No bed rest.
Yeah. But reassurance by doing an ultrasound and
Yes.
telling her that if your sac, the hematoma size is small, Suma will tell how many days bed rest, Suma?
No bed rest.
No bed rest. Swapna?
Rest.
No bed rest. And Harsha. Harsha loves the mother-in-law. You should trouble the mother-in-law for some time. So she will say, at least 48 hours. Nahin, Harsha? No bed rest?
No, sir.
Psychologically, I tell them take bed rest, be at home, rest at home, okay? And when the bleeding stops, come back after 7 days and then we'll take the call. Okay?
Yes, sir. Yes.
Because after the IVF, they have conceived. So it's not an easy thing to do. Okay.
At least for psychological reasons, we should advise them bed rest.
Absolutely.
Yes.
Do you believe in increasing the dosage of progesterone, Harsha?
So practically, evidence-based, there is no recommendation.
No. What I told you in the beginning, If you're talking evidence-based, I'll go to PubMed and search it. What do you do? How do you make
So
potato
if I have, yeah, if I have given only vaginal and probably if the adherence is poor, yeah, I'll try to add on the injectables or any other form of progesterone.
Injectable, aqueous or oil-based?
Sir, I'm giving aqueous to all my patients now.
So 50 milligram aqueous every day subcute.
25
25,
milligrams.
sir.
25 milligrams.
50 is also available now.
Yeah, it's available, sir.
Yeah.
Okay, but you prefer 25. Okay, Suma?
Yes, sir. If she's on vaginal, then I would also supplement with injectable, sir.
But no flavor for oral progesterone, Sarda?
Oral progesterone, as it is not so tolerable. And because of the first pass effect on the liver, there are more side effects like nausea, vomiting and all. And some people complain of vertigo also. So
Okay,
I don't
got
like,
it.
prefer to increase the oral dose of progesterone. Except for vaginal and intramuscular route is okay.
Okay. And for this is for how many days, Swapna?
Sir, I continue up to 12 weeks of pregnancy, sir, actually.
Means now the vaginal bleeding has happened at 7 weeks. So 7 weeks onwards till 12 weeks, you will give oral progesterone, injectable
Vaginal,
progesterone.
No. Actually, we start with vaginal progesterone, sir. If she had an episode of bleeding, we add on some progesterone.
The add-on progesterone, when does it stop?
Usually, I give intramuscular progesterone. If she has an episode of bleeding, I will give it for 3 days and then stop it. And then routinely vaginal progesterone, I continue till 12 weeks, sir.
Okay. SCG injection, anybody gives? No?
No, sir.
Everybody is doing freeze-all and FET cycles?
No, sir.
Then endogenous estrogen will come, no, with progesterone.
There is no extra benefit by giving HCG along with progesterone. Progesterone will be enough to support the pregnancy.
If you look at the recurrent pregnancy loss guidelines, if I go there, okay, SCG is equal to progesterone in recurrent pregnancy loss. Doesn't matter, but you don't want to give. Okay, don't give.
We don't want to combine both together.
Okay, if the patient is on aspirin and low molecular weight heparin, which one you will stop?
Aspirin.
Harsha?
Yeah, aspirin, sir.
Suma?
Aspirin.
Sarada?
Aspirin, sir.
Sukruti, heparin?
Sir, both, sir. If she is
Actually,
having an episode of bleeding, we'll stop both for a while. And depending upon the need, then we'll restart it again, sir. Until she has the stop.
It's a more indicated, more causes by aspirin than heparin.
Yes, sir.
So first thing is you stop aspirin and look at why has heparin been started.
Yes,
If
sir.
the heparin has been started for APLA syndrome, then you continue. But if it's an empirical thing, then you can
stop. Yes.
Tranexamic acid and ethamsilate, can we give during pregnancy, Sukurti?
Acute episode, we can give tranexamic acid.
Tranexamic acid, we can.
Category which drug?
B.
B. Perfect. That's it.
B.
This is a new drug, alpha lipoic acid called ALA, available on Amazon. Lots of papers. I have used it very, very regularly. 1 tablet TDS, superb. It's one of the oral amino acids. Okay, helps in absorption of the hematoma very fast. Okay, there are new papers talking about vaginal. I am talking because here my own publication is not out, but my experience is ALA works very good here. Prophylactic antibiotics. Suma likes giving antibiotics. Which Suma? For hematoma bigger, you know, it might get infected. So I like to give them antibiotics. Do you give or no?
Yes, sir. I give prophylactic.
I knew it. What antibiotics?
Erythromycin.
Azithromycin group. Okay.
Yes.
Okay. Harsha? Very tricky, sir. Very tricky. Well, if the hematoma is near the cervix, I will give. If it's near the fundus, I may not give. Is it?
I generally don't give, sir, but
Okay,
yeah,
good,
if it is prolonged bleeding for many days and large hematoma, yes, I tend to give, yes.
See, that's what I presented the first. What you do is what I want to know. That is what the message. Prolonged bleeding, okay? Not getting controlled by injectable progesterone and oral progesterone, okay? You need to worry because the blood is a culture. Infection will happen, it will get dropped. Maybe giving antibiotics will work. Here is there are no guidelines available. So you may give, okay? Fine.
Sir,
Sukurti,
can I intervene, sir?
Yes, yes.
Alpha lipoic acid, how many days you are giving, sir, for TID?
I give for 1 week.
1 week.
Yeah.
Okay.
It's a potent antioxidant. There are lots of papers on this subject.
Okay.
Last line I've written, elective single embryo transfer. Okay. So what I'm trying to say is prevent multiple. So the episodes of bleeding will be less. Okay.
Yes.
Harsha is finding something funny, I think. No, Harsha? Ectopic pregnancy. When do you suspect ectopic?
When there is any associated bleeding with abdominal pain.
You are going too far.
focal
You are going too far. You know, till that level, it should never reach in an ART consultant's hand. You did one beta ECG today.
Yes, sir.
One beta ECG after 48 hours
48
or after
hours.
5 days.
If
What?
there is no doubling of beta HCG
Yes.
value, then we have to suspect unhealthy pregnancy.
And at what a beta ECG level you should be able to see the pregnancy, Harsha?
It's 1500, but at 1000 onwards, I think we can start doing an ultrasound surveillance. Yeah.
You know, sometimes the radiologists have a little problem. If there is a bleeding vaginally, they don't try to do it TVS. But what would be the best methodology, Swapna?
Transvaginal, sir.
Transvaginal, and it will not affect, right? Now I want to know, you have done a ultrasound when the beta ECG was around 1500 or 2000. Okay. What is your management strategy? Conservative versus operative. Will go
Conservative.
Conservative.
If she is hemodynamically stable, then conservative. Sir.
Conservative. Okay. You primarily did her IVF for tubal factor.
Yes, sir.
Still you'll go conservative?
No, sir.
No, you can differ with me. Huh? We can have a discussion on this. I'm no one by position. It's a discussion. Remember, we all are discussing and people are listening to our discussion and taking messages out of us. Swapna, when will you operate? When will you not operate?
Patient is hemodynamically stable and beta HCG is less than 2000. There is no evidence of any fetal polar cardiac activity. Still, I would like to give a conservative management only, sir. If still the patient fails, the beta HCG is not dropping and patient is becoming like clinically unstable, then I would like to take her for surgery. Initially,
you all are not understanding. See, you are an ART consultant. You are supposed to take a decision on that stage itself. Operate or medical.
Beta HCG is less.
No. What I'm saying is salpingectomy. When will you think of doing a salpingectomy?
If the tubal factor, if I have done the IVF due to tubal factor, definitely I will do salpingectomy, sir, to prevent recurrence of ectopic. Okay.
And neosalpingostomy? Do you believe in doing neosalpingostomy in IVF conception?
No, sir.
No.
Okay. In IUI conception?
That too with.
In IUI conception?
Sir, any kind of conception, no, sir, because if the tube is once damaged, it's always damaged.
Excellent. You know, there is always one thought in my mind. If one tube is damaged, do you think the other side would be normal?
No, sir. Usually the infection is bilateral, sir.
So
but it can be.
It's like this. It's my right ear is damaged. Necessarily my left ear is not damaged because they are two different cavities.
It could be bilateral, but it is not always that both are in. Not always.
But we are worried about the society norms. We are always worried about society. Now, if you took at both the tubes, she might have a social problem. Okay. So we have to take the call according to the situation. Okay, fine. But always remember, if she had ectopic post IVF and you've removed the tube, one tube is inside, you're doing the IVF again. At the time of embryo transfer, what safety measures you'll take? Harsha.
We don't transfer it too close to fundus
Okay.
to avoid the ectopic. And transfer media, how much we are taking also matters in causing ectopic. So probably we should be careful. Yeah, and day 5 transfers would be better. Frozen transfers could be better.
Traumatic versus non-traumatic.
Always non-traumatic.
Always non-traumatic.
Excellent, guys, you're going great. So very commonly seen with tubal factor, traumatic factor, day 3 more common with day 5. Okay, heterotropic, only one thing. Suma,
Yes.
you are heterotropic pregnancy, will you do conservative treatment?
Conservative. Yes, sir. Try to conserve the intrauterine pregnancy.
And the extrauterine?
Extrauterine. So it depends, sir. See,
Surgical management.
mostly it's a surgical management, but if we have a
अरे भाई एमक्योर का लोगों को बोलो सुमा देवी को, सुमा मैडम को एक कॉफी भेजो, फिल्टर कॉफी, double shot. Okay, it always has to be removed, right?
yes.
What precautions Swapna will take while doing heterotropic pregnancy removal?
Tubal
Why
ectopic.
so?
If it is a tubal ectopic, I
With
would like,
intrauterine pregnancy.
yes, with intrauterine pregnancy, I would like to go for laparoscopy straight away and remove the tube, sir, without thinking of any conservative management.
Arey, but that anybody can
During
do.
Yes, sir. During the day of surgery, if she is only on vaginal progesterone, I will add on some injectable progesterone, sir, to support the luteal pregnancy, and I will serially follow up her. Like before surgery, I'll do an ultrasound, and immediately post surgery.
And you told the patient to be taken to the theater, but sister wanted to impress you, so she went and she cleaned the parts and she put in a speculum and she put in.
Definitely, supine position only we'll do, sir, not in the lithotomy position.
First of all, there should be no vaginal manipulation.
Manipulation should not be there.
That is sufficient. Position, what you want to do, you do. Okay.
I'm comfortable
Am I
with
correct?
supine position.
And in all these things, this KCL injection and all, I have never done it. I have no experience. But if the vaginal, there is a bleeding, there is always remember rectally one can use progesterone. And it will give you same absorption.
Yes.
The only thing is your compliance should be better than the patient's compliance to tell the patient to take rectally. Multiple pregnancy. Okay. So we know that it's very common with multiple number of embryo transfer. Okay. And it's because of now we are reducing the number of embryo transfers. So how do you decide the number of embryo transfer? Sukruti.
So based upon the number of the embryos she is having and the quality of the embryos, sir. So if she's having a good number of embryos which are of good quality, then probably I would like to transfer a single embryo, sir, which is of blast.
But but I will give you
day 5
example.
single embryo transfer.
For her, but she has multiple embryos, that's why. But she has only 2 embryos.
If she has 2 embryos, then we have to check for the quality, sir.
Quality top class, madam. Your lab top quality.
Then age of the patient, associated factors, and then decide for the transfer.
That is very important, no? Previous hysteroscopic surgeries, previous abortions, previous second trimester losses, all that has to be decided beforehand rather than anything else. Okay. Monozygotic twilling. Okay. Always look at for the twin peak sign. Okay. I don't do my ultrasounds. I send it outside. For earning that 1,500 or 2,500, I do not have 20 minutes. Rather than that, I use 20 minutes to counsel a patient and get patient's confidence. Single embryo versus double embryo transfer. Single embryo transfer, much better, almost same pregnancy rate with multiple pregnancy going down. So what in European say, they say, transfer as many times you want to transfer, but transfer one embryo at a time. Okay. So, there is a dichorionic diamniotic pregnancy, okay, or a triplet pregnancy, okay, and patient, you are going to do embryo reduction. How many of you will agree to do embryo reduction for triplets? Just raise your hands. Okay. Now, how early or how late or what is the correct time to do embryo reduction? Sarada?
Around 12 weeks, 10 to 12 weeks gestation, sir.
10 or 12?
12.
Why?
Because I'll wait for to see whether any of the gestation is vanishing on its own first point.
Very good.
If it does, if it doesn't vanish, okay, then she has to go for reduction only.
Okay. Anything else? Any other reason, Harsha?
NT-scan.
NT-scan.
Correct. NT-scan. Now, which method do you all prefer? Transabdominal or transvaginal with our OPU needle going inside the uterus and doing termination?
So transabdominal.
Transabdominal is better.
Sir.
Transabdominal.
So,
Swapna, do you agree? Transabdominal?
Transabdominal.
Suma?
Transabdominal, sir.
Okay. Harsha?
Yes, sir. Abdominal. I
Okay.
would do with abdominal.
Do you all do it or do you send it to fetal medicine expert?
We send it to the fetal medicine expert, sir.
Experts.
There is one thing I forgot to mention here. Look at something. What is it? What needs to be checked before doing this? Something needs to be checked, no?
So fetal anomalies.
No. Some blood test.
Overlapping of the sacs.
Some blood test.
First time is to
But
screen double.
Screening combined.
Blood
combined first
test.
time is
No blood test. I'll come back to Sarda. Combined.
Coagulation.
What simple blood test?
Sir, coagulation.
No, between husband and wife. What blood test?
Blood groups.
Grouping type.
RH immunization.
Midi. My point.
Mm.
Short term, long term complication.
Chances of miscarriage will be
Miscarriages will be there.
Yeah. And long term.
ISO immunizations.
Okay, so basically, how do you select? You know, one of my twins had a placenta previa, okay, and the second twins was on the top. My radiologist took the lower one. He's expert in Bombay, but generally it is the very accessible to the skin. One which is lagging behind, or one you think there's an NT is larger, you should take that one. Don't try to do too many manipulation, and with thinnest possible needle. And there is a definitely reduction in early preterm delivery. And there could be loss because of this preterm, PROM, and early abortions can happen. Now, I want to know your take on twin pregnancy patient. She is CEO of a big tycoon company, okay? And she came to you for a baby, but now she has babies. Now she requests you that I want to do embryo reduction. Will you agree or not agree?
Yes, we agree.
Yes.
twin pregnancy, usually we don't ask them for, we don't advise them for a fetal reduction, sir. If it's triplets, more than 2, definitely
Triplets.
yes.
Patient's choice, sir.
Explain the pros and cons of each.
No. Suma said patient choice. Correct. Sarada?
Yes, sir. We'll counsel the patient. We'll tell her all the complications
No, no,
that
no.
she
But
has.
what is your take? If the patient wants to do it, what is your take? Will you do it?
For twin pregnancy, no, sir.
No?
No.
Harsha?
If the patient insists, yes, I would definitely, after counseling the risks, yeah, I would go.
No, now I will ask you, all of you, you have one monster at home. At one time, you have been given 2 monsters at home to handle. Will you be able to handle them?
No.
No, sir.
If we cannot handle it, we expect others to handle it. At the age of 40, how it is possible? Don't you think so? Is the correct way of thinking?
Yes.
Oh, lovely questions, sir. Lovely questions. When do you stop these? So I'll start with progesterone, vaginal or dydrogesterone, Sukruti.
Sir.
Sukirti,
Sukirti, sir.
Sukirti, sir. By the end of this panel, I will learn how to do. Sukur, it happens with me. Okay, vaginal progesterone, when do you stop?
Sir, 8 weeks, sir.
8 weeks?
Yes, sir.
You don't get sponsors, vaginal progesterone sponsors, you don't get too many. Okay.
Once
What should be?
the uteroplacental shift happens, then I would like to stop the progesterone, sir. Exogenous
Okay.
progesterone.
Anybody in this panel continues vaginal progesterone since last 1 year till 32 to 34 weeks?
In gestations, I continue.
Twin gestation, you continue. Okay. That's very, very rational thinking of Sapna. Suma?
Short
No.
cervix, I'd like to continue. Sir.
Okay, that will come. So generally, she says it's 8 weeks. Anybody wants to differ with 8 weeks or 10 weeks
12
or
weeks.
12 weeks?
sir.
12
We
weeks.
give it 12 weeks.
12. So Swapna gets higher sponsorship than Sukurti on vaginal progesterone. Okay. Low molecular weight heparin, Harsha, started for recurrent implantation failure, not for APLA.
Then I would go only till 20 weeks, proper placentation till it is established.
Excellent answer.
And
Which
if it is
you
APLA, I
will go, which way? It's the second way of trophoblastic invasion we have to wait for. Okay. Estrogen, Suma.
12 weeks, I'm using it in 12 weeks.
Sarada, estrogen.
I will taper the dose which was initially started slowly week by week after the fetal heart has established, and I'll continue till 12 weeks and stop after 12 weeks.
What is
And
the
if it
normal,
is
what is the normal dose in FAT you use, Sarda? FAT, how much estrogen do you use?
I started first initially with 2 milligrams TID, sir. Slowly
then?
after 5 days, I increase it to 2 tablets TID. After 7th day, I'll keep checking her ultrasound. If her endometrial thickness is improving, it's not improving, I'll increase the dose and give at least complete 10 to 12 days of estrogen.
No, I understood. I understood.
Mm.
Okay. Anybody else want to differ here with the dosage?
should not be more than 24 milligrams estrogen. Overall dose shouldn't be more than that.
Which do you think which is the culprit for developing pregnancy complication, estrogen or progesterone?
Estrogen.
Estrogen. Progesterone is part of pregnancy.
Estrogen. Mm.
Why to give after 8 weeks? 8 to 9 weeks later, you don't need to give. I think there is a trick there. That's why in frozen FET cycles, with high dose of estrogen, we are getting preeclampsia and all those complications. I feel. Normally what I do is I start TID and I do give for 7 days and I do E2 level. If my E2 level is 220, okay, whatever is my endometrium, after increasing to 450 of estrogen, my endometrium is not going to respond because that is the normal estrogen required by the normal follicle, single follicle. Increasing the estrogen does not increase the endometrial thickness. This is basic we need to understand. Try and do it in your practice. Look at the blood flow. If the E2 is say 270 with 1 TDS, look at the blood flow. If the blood flow is not good, you increase the blood flow by giving sildenafil, heparin, L-arginine. Repeat the scan after 7 days. If the blood flow comes, then you do the transfer. You will still get pregnancy. Higher estrogen is the culprit of causing subendometrial vasculature thrombosis, which is prevented by heparin. That's why we need to give heparin. Okay. Aspirin. Dr. Seema Pandey, I am in the panel discussion.
Oh, sorry.
Yeah. Aspirin.
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 Are there like APLA positive? Then
Are
we would-
simple ray. Aspirin, if bleeding happens, you stop, you start again after 2 weeks. Otherwise, you continue throughout till 34 weeks. Simple. इतना क्यों सोचते हो डर डर के? मैं हर क्वेश्चन में पकड़ूंगा नहीं तुम लोग को. Steroids. Anybody of you all give steroids? You know, मेरा favorite है. Recurrent implantation failure में. Anti-thyroid antibody में. Sudha, what do you think?
Yes, sir. It kills the natural killer cells in the endometrium.
But do you give steroids?
I don't give because there is no evidence of improving the clinical outcome with
Oh, so
steroids.
you
sir.
want one white man to come from there and say from tomorrow you give steroid and you all start getting steroids.
So we generally don't give steroids, sir. In cases of RPL or recurrent implantation, maybe then we can give them.
If you give steroids, okay, say 5 milligram 3 times a day, beta HCGs come positive. What would be your cutoff? When will you stop doing the heparin, the steroids? At what weeks would you like to stop the steroids?
And after it is positive, we start
Positive.
tapering the
Tapering,
Mm,
yes.
Tapering the dose.
Yes, and once the heartbeat comes, one should go off. Okay. L-arginine and vaginal sildenafil. When do you stop?
L-arginine we can continue, sir.
Very good.
And sildenafil probably after
So,
the hospital start.
sildenafil, when you stop?
So once it is beta HCG is positive and the heartbeats have started, we can stop sildenafil, sir.
Okay. Anybody else want to
So we
continue?
don't give sildenafil at all. Like it's only in regularly we don't give sildenafil at all. So only.
No. So that's what I'm telling you. See, what is this? This is what your patient goes to Bombay to somebody, and in that patient sildenafil is used. The gynecologist should know what to do with that. So sildenafil, if at all been used, what weeks will you stop?
Once the heartbeat is established, you can stop the sildenafil. Routinely, we are not using sildenafil, sir.
I use lot of sildenafil. It is a category B drug. It is used in primary pulmonary hypertension. N number of babies are born when the patient is on sildenafil citrate. Okay, it's a wonderful drug in a FAT cycle because it's acting locally. Okay, and it is producing the desired effect of increasing the blood flow to the endometrium, which in case of recurrent implantation failure and thin endometrium you want. Okay.
What is the dosage you are giving, sir?
25 milligram 3 times a day vaginally after soaking in the tablet with a little bit of water. And I give from when I start estrogen. Only estrogen is not with progesterone, it's with the estrogen. So you need to develop the vascularity from the beginning. But that's
Day 2 you start.
no, day 3, day 4, once the bleeding stops. Anybody uses immunomodulators? That that white color solution every monthly they give, or Barglobe every month, every 21 days. Arey, somebody must be giving, somebody. Abhi last Suma, do you give?
No, sir.
अरे क्या यार तुम लोग तो ऐसे बिहेव करते हैं. पैनल डिस्कशन है.
No, sir.
No, I give recurrent implantation failure, recurrent
Yes, sir.
early pregnancy
Recurrent
loss.
miscarriages we give, sir.
But recurrent miscarriage patient comes for IVF, then you have to give, no?
Yes.
So do you give, no?
Steroid.
Barglobe we don't give, sir. Sometimes intralipids we give, sir.
So once she's pregnant, you continue intralipid every month?
No, sir.
You don't? But according to the statistics, it has to be continued every 21 days.
Yes, sir.
Okay.
So,
And the favorite of all again, bed rest.
No.
no.
No,
Mhm.
I
No.
expect this answer in South. I expect. But in
Even if we
certain-
don't advise, they will take, sir.
I understand. But if you tell, then they will stick to the bed and tie themselves in the bed. Okay, and they'll do everything on the bed, which I feel very bad because that produces more stress. You know, have you ever tried doing this? Try today this. I request you 20 minutes to sit on a chair without a mobile. Okay, and just sit and see the number of thoughts you get in your mind. And you decide that I am not going to think about this. You decide I am not going to think about this. You know, I'm not going to think about my husband today. Okay, I'm not going to think. See what happens to your mind. Whole thing will become Suma. You can laugh a little bit. You are the only one who is not laughing. Others are all laughing and enjoying. Are you sleepy?
No, sir.
There are lots of patients outside. The Visakhapatnam, no? You are in Visakhapatnam?
Vijayawada, sir.
Vijayawada. It's from Vijayawada. It's not gone outside Vijayawada, no? Okay. Now, first trimester screening. Does it need to be modified in singleton pregnancy? Swapna?
So the altered hormonal milieu, if we are going for a fresh transfer, we have to inform this to the lab people that it is an IVF pregnancy.
Okay.
And in case of donor oocyte IVF also, we have to mention that it is a donor oocyte and the age of the donor. If it is
Excellent.
twins, definitely we have to mention it is multiple gestations. Because the
Okay.
beta HCG will be altered, so the values will be altered and
Values
the
will-
false reports will be there.
If somebody is giving SCG support, see, we always talk about IVF, but in some people are giving IUI and SCG support. So Suma, what will you tell them?
We
Do
have
you
to stop HCG 2 weeks prior.
Excellent, Suma. Excellent. Very good. This is the only way to encourage them. And for surrogate mother, what do we do?
It's the age of the biological mother.
Perfect. Okay. Dual marker. Always mention twins or vanishing twins or bleeding during pregnancy. But donor is a donor oocyte. The
Donor
age is-
oocyte.
Yeah. HPS. All 100% mark to everyone till now. Wonderful. First trimester additional screening. और बढ़ाओ और आगे क्योंकि मेरे ग्रेट ग्रैंडमदर के टाइम एनटी भी नहीं था. Now I want to do PIH profile. Now what do we do? Anyone can take it.
We try not to.
Growth factor. Sir, we do
Cell-
first trimester screening, which includes age of the patient, NT measurement, blood trimester, which includes
Combine it with ultrasound.
blood parameters, which include beta HCG plus PAPI. And for PIH screening, we do placental induced growth factor, PIGF we do, sir.
Okay. All patients of ART?
Now for IVF pregnancies, definitely we do, sir.
Sukruti, you also do all patients of
No, sir.
ART?
No, sir.
Okay. Any particular patients?
Yes, sir. Any previous history of pregnancy-induced hypertension or
See,
any cancer causing-
I'll give you one hint, Harsha. You do
Sir,
go ahead.
Sir, I think for IVF patients, we have to do this PIH screening definitely because they come under the risk category of having the preeclampsia in their pregnancy. So yeah, I prefer doing PIH screening, sir. Preeclampsia screening for the IVF pregnancies, apart from the other indications when we have to screen like obese, history, and coagulation disorders.
risk factors are there, then probably we will ask them to get it done,
And
sir.
mostly we
Without
do
risk factors, plain, I mean, only ART pregnancy, I would not advise, sir.
So
We do
there
FET
are this only ART pregnancy, there is special ART pregnancy.
That itself is a risk
cycles.
factor, sir, but still, if she is not having any associated risk factors along with ART, I would not advise her, sir.
May I add something?
I will do simple. I will do this preeclampsia screening by uterine artery Doppler.
Yes.
Uterine artery Doppler normal. I may not do all those complicated tests. Okay. because that will complicate my counseling more complicated, because I don't understand those PIBF and what the PAPE, low, high, I don't understand. Okay, go, Harsha.
Yes, sir. I do uterine artery Doppler only, sir.
Okay, Harsha.
Sir, I would like to add one point.
Yeah.
We are doing universal screening for Down syndrome by double marker and along with the NT scan,
Perfect.
which is actually not avoidable. We cannot prevent that. But why not doing? Why don't we do it for PIH, especially when we know the risk? We can absolutely avoid it, at least prevent the preterm preeclampsia when we are having evidence. Aspirate trial says, and many have tried, and it has been successful.
My patients of IVF are all on aspirin.
Sir, pardon, sorry, I didn't.
All patients of IVF are on aspirin. My patients.
On 150 mg, sir.
150 mg. Now you tell me. I'm telling you.
Probably, yeah, we can increase the dose from 75. If you have started, we can go on and increase to 150.
So to increase the 75, you do the test. Okay, good. Anything else you add? Then double calcium, fish oil, and no, I'm asking. Really, I'm asking. If I'm doing the test, L-arginine.
Protein-rich diet we advise, sir.
Protein-rich diet. Okay. So
protein-rich diet.
What I now suggest, if you do a test, if it comes abnormal, you should have the answer. Then you should not say, okay, you have the risk of getting hypertension and pregnancy. Now what to take? I don't know. You have these 5 options. At least give something to them. Am I going correct?
Yes.
Or wrong? Okay, fine. And this is the mean MI.
PI, uterine artery.
Yeah. Okay. Oh, favorite flavor of the month now. NIPT, NIPT. Suma, NIPT. All patients?
No, sir.
Then
I'll offer it to them, and it's their informed choice. I'll just document whatever they want. If it is indicated.
Have any risk in the NT, with the NT scan or age? If we get a high, high risk, then we will ask them to get an NIPT done, sir. But golden standard is always amniocentesis.
That's all right. Harsha?
Sir, when we are doing double marker, we do it like in 2 categories. One is the biochemical and the other one is a scan. So only isolated biochemical parameters, if they are elevated, then yes, I would like to go with NIPT, just because the sensitivity is more. It is around 95%, more than 95%. But otherwise, the gold standard, as she said, it is definitely amniocentesis when both the markers like the scan as well as biochemical, if both are altered, I would definitely go for amniocentesis.
Okay.
Yeah.
And
also
Dr. Sarda.
Yes, sir.
Is a fantastic IVF specialist. She made one 40-year-old lady pregnant with her own eggs. Okay. Now,
yes, sir.
Double marker, NIPT, amniocentesis. Tell me what, Sarda.
First trimester, I will go for a double marker, sir, along with the combined screening, NT scan with double marker.
It is normal.
Yeah.
It's normal.
It is normal. Then I will follow her serially, sir. Again, for the next second trimester, I'll do a quadruple marker also again. And if the levels are elevated or like alpha fetoprotein, HCG, estriol, I'll check for all the parameters. If anything is in problem, then I will offer her amniocentesis. But if she's not agreeing for amniocentesis, because IVF people are very scared of invasive procedures, then I prefer asking her to go for NIPT, because NIPT is not available in my practice.
Anybody has a different answer, Swapna?
The patient.
Cell-free DNA.
One minute.
Cell-free DNA screening also can be done.
I understand. Wait, Swapna.
The patient is affordable. Financial issue, because NIPT costs around 25,000 rupees, I believe. So NIPT is 99.9% sensitive. But if the patient is not financially affordable, I will prefer to go with double marker screening plus NT and scan only, sir. If the patient is affordable, definitely I offer the NIPT test.
If that is missed, then we can go ahead with the quadruple, but not both. Either of the tests is fine, sir, to determine the risk. Then we would like to go ahead, even though she is 40, initially age-related risk.
Which is more sensitive, quadruplet or double?
Quadruplet is more sensitive, sir, because, but it is a little later we will detect the problem. If you want to do it still earlier, then we have to go for double, sir.
I'm not the
NIPT is
expert.
more sensitive
Okay.
of all.
Okay. Very clear. I will do a double marker. Double marker comes normal. I'll tell her that silk there can be chance you are low risk or high risk. Your choice. You want to do NIPT, you can do. But according to me, this report is normal. There's no need of doing anything. Okay.
Yes, sir.
Okay.
Because my great grandmother also became pregnant. Right? Ultrasound is normal. Biochemical parameters are normal. Everything is normal. Now, how more normal you want normal?
We can check it in the TIFA scan later, sir.
TIFA scan.
म्हणजे आता हा कुठला? हा. Triple or quadruplet marker, you say quadruplet marker, right? Where the neural tube defect can be picked up here. Okay. Need for amniocentesis versus NIPT.
NIPT.
No.
Sir, if
When do you do
Yeah.
amniocentesis? When you do
Amniocent.
Sir, if the double marker with the age-related risk and the NT are high, we advise amniocentesis, sir. But if the patient opts for NIPT, because amniocentesis is golden standard, in still some cases can be missed in NIPT also, we counsel them, sir. If they opt for amniocentesis, we go ahead with the amniocentesis. We also explain them the risk of miscarriages associated with amniocentesis.
Simple is NIPT comes abnormal. Amniocentesis is the answer, right?
Yes.
Also
Am
for
I good?
multiple pregnancies, we can't.
Yes.
do-
NIPT, so you're not going to do amniocentesis of both the sacs unless it is indicated, right?
Yes, sir.
Just imagine A sac, B sac, C sac. No. Anomaly scans at what week of gestation?
To
Suma?
20 weeks, sir.
18 to 20 weeks.
18 to 20 weeks. Any add-ons that there?
22
Echo
weeks
also
probably
suggested.
echo of the cardiac.
One person. Swapna?
Fetal echo also we suggest, sir.
No. With the multiple malformation scan.
Along with the cervical length, routinely we check, sir.
Yes, and
Cervical length.
Dopplers.
And
which
uterine
uterine artery Doppler.
Uterine artery Doppler.
Interval growth scan. To
28
detect
weeks.
directly 28 weeks. Okay, good. Suma?
Every 4 weeks at least. And if there is any problem, then every 2 weeks.
Every
Okay.
2 weeks, if there is a problem, yes.
5,000 rupees, 4,000 rupees per scan. Very nice. GDM screen.
Yes, sir.
The patient is
Yes.
already like advanced age PCOS patient with high BMI. In the first visit itself, in the first in the first trimester itself, I OGTT, sir. Actually, if the patient is a low risk patient, in the 5th month, along with the TIFA scan, we do OGTT, sir.
In the first trimester itself, we do it for everyone, sir. It's a universal screening.
What is it called as?
Sir?
Dipsy.
Dipsy. Dipsy.
Mm.
Okay. Last line, everybody agrees? Fetal echocardiography for all ART patients?
Yes.
Harsha doesn't agree. Harsha says no fetal echocardiography. Okay. So we have a situation here. Harsha says no. Harsha, why no?
Yeah, one may be the cost. Other thing, if
See,
at all that
see,
three vessel
see.
view is good on
See. Basically, ART patients have lots of money.
Money, yes.
To spend
Cost
on
should not be a
to spend
factor.
on investigation, but when it comes to give it to you, they don't have money. Okay, I agree. Everybody agrees.
If there is good TIFA scan with good four chamber view, three vessel view, everything is fine. I don't think there is need for.
So she has a radiologist who is very confident. He says at 20 weeks, I will do malformation, come cardiology scan and I will be okay, right? Okay, fine. We'll not discuss. Cervical length, ultrasound versus digital.
Ultrasound.
16 to 24 weeks ultrasound, sir.
Okay. Okay. Uterine artery Doppler, interval scan 4 weeks, GDM screening, first visit DIPSI. Okay. Birth defect with ICSI, they are more than IVF, and patient has to be counseled. Recommended is to do a 2D echocardiography in fetal in all ART pregnancies. These are the most commonest one. Well, I have not seen them, but hypospadias later date I have picked it up. People have said, and some here and there. I have never heard of this syndrome. Cervical length. This is transabdominal. This is
We are seeing more of cardiac defects, sir. Cardiac anomalies are being more detected.
Okay.
In ART pregnancies.
So vaginal examination will look at the external cervix, whereas the opening happens at the internal os in a preterm or PRM, whatever. So it is the internal os which needs to be under supervision, not the external cervix. So digital examination is not the criteria. Ultrasound, 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 and on top of it, TVS. Actually, you can do transperineal scan. You don't even go inside. It's a long view, you know, and you don't even touch the cervix. There are people who are worried that placenta previa, they don't like to do TVS. Placenta previa, placenta is here. You're doing the scan here. How the bleeding will happen? I regularly do for all placenta previa also a TVS scan for doing cervical length. Okay. Obviously, you have to be gentle and you have to be away from the cervix. That's all. Okay. Preterm labor. Okay. So we all agree there is increased risk of preterm labor in ART. Okay.
Yes, sir.
How do you treat or prevent preterm labor? So we will first learn how to prevent preterm labor.
Avoid multiple pregnancies, sir, as much as
Excellent.
possible.
Excellent. Singleton.
Singleton also there is risk of preterm delivery.
Yes, but how to prevent it?
Infection control.
One minute. Harsha is talking about infection control. So actual infection versus prophylactic infection. What is it? That's okay. What you do? Huh?
Actually, we have to take a vaginal swab and see for the infection, sir. But routinely, we are not doing.
So what do you do routinely?
We just, if at all we are suspecting, we ask her for any pain, abdomen or anything, complaints or symptoms. Then depending on that, we start her on.
See, by the time you complain, no, it's gone.
Doxycycline prophylactic will end it, sir.
The pregnancy. Sudha.
Pregnancy, no.
Prior,
prior US, but during pregnancy, nobody uses vaginal antiseptics for their pregnant patients. No prophylaxis. Okay, good.
Not prophylactically.
probiotics sometimes.
Yes, something which is coming up.
Probiotics, yes. Yes.
What
Probiotics.
what about sex during pregnancy in ART pregnancies? And do you believe that sex could be responsible for preterm labor?
Yes,
Yes,
sometimes.
release of prostaglandins
Because
some
Harsha?
prostaglandins and that can cause contractions.
Sir, one is the entry of the infection. We are making it giving a way to the entry of infection. Second is, as she was discussing, the prostaglandins in the seminal fluid could cause the contractions. Probably absolute refraining from the intercourse is not possible. Maybe we can suggest them the barrier methods or something like that.
Yes.
At least first trimester could be avoided if at all it is possible. Maybe I would suggest.
I will tell you, you put up a paper in your consulting room, take a vote of all 36 weeks pregnant patient of ART. You will get 0% sexual intercourse rate. People don't do anything. Even if you tell them that only you can have foreplay, they don't want to take the risk normally. Okay. The other thing which proves is humans do sex for recreation. Animals do sex for procreation. When the dog or a horse is pregnant, they don't do sex at all. So humans were made like that only. But we found recreation in that. That's where the problem started, I feel. Is there a drug called isoxaprine duodenal retard? Can it be given to prevent preterm labor? Yes or no? Swapna?
The patient comes with preterm labor pains or contractions.
No.
Not prophylactic duodenal, I don't give,
No.
sir.
Sarla?
Yes, sir. I give prophylactic duodenal.
Sukruti?
No, sir. If she is in
Harsha?
labor, then yes, sir. If she is not
Sudha?
in labor, prophylactically, no.
Only if she has an irritable uterus or she complains of backache or something like that, then only I give. Others never
No,
prophylactic.
no, it's Suma, sorry.
Sir, I give it till we have time to give steroids.
Prophylactic.
It cannot prevent, but once the patient is in preterm labor, at least till we have the
But probably as one of the resort, yes.
It has been clearly said, this drug duodenal, okay, to be banned now, okay, it's not to be used at all. You read the guidelines, it's not to be used. It has got severe cardiovascular problems. So prophylactically, there doesn't exist at all, okay. Especially the terbutaline subcute one is the most dangerous one, okay. Now, to prevent preterm, now she is in established labor, okay, preterm. Say I give example 1.5 centimeter cervical length with 1.5 centimeter internal loss, and she is getting contraction but no leaking. She is 31 weeks of gestation. What is the drug of choice? Suma, I am talking about thinking out of the box.
Nifedipine.
Sada, have you used
Nifed-
nifedipine?
Yes, sir.
How?
Orally, I give her, sir.
How many milligrams?
20 milligrams. First, I give her TID, but I keep monitoring her BP. If she's not responding, I increase it to 4 times also. Initially, for first 2 to 3 days until the contractions stop.
First, you have to stop the active labor. How do you stop it? Swapna?
Progesterone support can be given, sir.
Progesterone is a supplementary. Means the main action is progesterone later date, but acute stage, what you do? Swapna?
We can give her a magnesium sulfate drip also, we can keep, sir.
So what do you give, Sarda? That is important. I can give 1,000 things. What do you give?
If she is not responding, I give magnesium sulfate drip also, sir. Nifedipine and magnesium sulfate.
First of all, we should rule out the cause of preterm labors. I would start an antibiotic first.
Absolutely. Right on the dot. It's urinary tract infection.
Yeah,
somewhere there is a cause. So you will give that. Okay.
Yes.
Nobody use atosiban?
It's not available for us, sir.
Why?
We don't use it, sir.
We don't.
Atosiban is the drug of choice in preterm
It's
labor.
not available here, sir.
It's not available, sir.
Okay, I'll make it available. Don't worry. I'll make it up. Harsha?
Yes, tocolysis with either nifedipine or atosiban with antibiotics and with steroid coverage.
Okay, Depin to be used in a dosage of 5 milligram.
20
milligrams
milligrams
TID.
One minute. 5 milligrams sublingually after giving 1 pint of ringer lactate. Every 15 minutes, you can keep giving up to 120 milligram. Okay. This is acute stage management. You have to stop it. Once it is stopped, then you can continue 20 milligram for another 72 hours till the time your rescue steroid has acted and you can transfer the patient or deliver the patient or go on to the next level. Okay. And progesterone is something very important. Anything for PROM specifically you do in your clinic?
Start her on antibiotics.
Take a vaginal swab.
Erythromycin is the drug of choice.
No, prevention. I'm talking of prevent. It already happened, then you hardly can do anything. I use vaginal pessaries, okay, between 22 to 28 weeks, okay, 2 times a week, okay, absence of sex, okay, and urine examination at least 2 times during this time, okay, and looking at GDM as one of the causes as to rule out PROM. Okay. And no sex, as I told you. This is what my formula is. Recently, there is a new drug has been launched for PROM. I don't remember the name, but I will let you know. But there is a drug, but there is no trial for it. Very small trials. Okay. Okay. For prevention of preterm
Sir, how
labor,
long do you use vaginal pessaries?
only for 4 weeks, 4 to 6 weeks.
4 to 6 weeks.
Yeah, that's it. Okay. Prophylactic
Okay.
surplus for preterm. Okay. This has been recommended, but the score happens with vaginal progesterone. The one thing which will prevent preterm labor is vaginal progesterone. Okay. And this is one paper which talks about vitamin C for prevention of PROM. It says you start from 14 weeks. Maybe one can give previous history of PROM. Okay. You can give alternate day and try your level base. After this 2013, there is not a single paper has come on this subject again. Okay. So let me be guiding you on this. Okay. Multiple pregnancy. Okay. Meta-analysis shows again increased risk of low birth weight and preterm labor. See, I told you 35 weeks is the twin pregnancy. 25% rate is the NICU admission, and the minimum days of admission is 8 average. 18 into 10,000 NICU stay. They don't have money to pay you, but they will pay here. You understand? This is direct costing. Fetal morbidity happens here. That's why you need to be aggressive. That is what I feel. Preterm PROM, aggressive. Anemia management, aggressive. Urinary tract infection, aggressive. Screen the patient repeatedly. That is what is more important than anything else. Systemic meta-analysis says vaginal progesterone score higher than any other intervention, either singleton or multiple pregnancy. Okay. This is twin pregnancy. Again, vaginal progesterone with either Peloton depot works the best. Okay. Okay. IUGR, another indication. Okay. Is there the increased risk of IUGR in this pregnant patient? We agree that. Okay.
Yes.
So how do you pick them up? By interval growth scan, right?
Yes.
Okay. Which are the patients
Yes.
who are at increased risk of having IUGRs?
Autoimmune
Again,
disorders, hypertension, chronic
hypertension.
Correct.
diabetes.
Okay.
patients.
Suma,
BMI more than 30, age more than 35, all the risk factors, sir.
okay.
Smoking, alcohol, BMI more than 30, age more than 35, hypertension.
Okay. Sukurti, IUGR, single umbilical artery is also very common in IVF pregnancy. Okay,
Yes.
how do you treat IUGR? Okay, I'll give you example. Okay, 28-week scan shows oligohydramnios, AFI of 8 millimeter. Okay, uteroplacental circulation normal. What do you do, Harsha?
So could you repeat it, sir, once again? Sorry.
AFI 8, blood pressure normal, uteroplacental circulation normal, all Doppler parameter normal.
Maybe I advise hydration, arginine, positioning,
Positioning means
left lateral when
Left
she
lateral
sleeps.
position.
Yes, yeah.
the husband to sleep on the right side and she should sleep left lateral. Okay, anything else?
Repeat
Yeah.
this.
And I keep monitoring frequently.
What?
Ultrasound.
How many times? Weekly?
The-
Doppler is normal.
2 weeks.
No,
2 weeks. You will do, Harsha, you will do weekly?
no, sir, not weekly.
No, go ahead. It's okay. Why are you scared?
No, I examine her clinically as well as ultrasound maybe every 2 weeks.
I asked her, we should ask her to check for her fetal movement and kick count, sir, at home.
Okay. Next
Okay.
ultrasound shows, yes, there is uterine artery resistance is increasing and there is a problem is setting in. Okay. Then what you do?
So if aspirin not
Steroid
start-
coverage and still.
She is already on aspirin. No, all your ART patient with
Steroid
aspirin,
coverage.
heparin, you give prophylactic, steroids are given, है ना? You have
Even-
given L-arginine. What else?
Still we'll follow up, sir.
Follow.
If middle
What I'm-
cerebral, till the middle cerebral artery and the ductus venosus, we still wait, sir, because it's too preterm.
But-
20 weeks.
I understand, but what are you treating her with?
Admit the patient, monitor. Sir.
Ah!
Mm.
But she can take the bed rest at home. Why Swapna admit?
28 weeks with
Suma?
already of diastolic flow. I
No,
can't
no,
say.
no. There is a treatment available. You're not reading it. You're not reading it. You're not thinking out of the box. You're still in the box. Everyone, get up. Suma, have you tried this drug? New drug, old drug? So common modality, you told me that amino infusion, L-arginine 3 times. You have not tested L-arginine any time. You don't feel like anything eating after 2 hours after that. Left lateral. There is no way to, sleep always on the left lateral. Then what? What else?
We have that Foresil tablets now, sir, and IUGR plus.
Foresil is for PROM. You got it correctly. It is the new tablet, Foresil for preterm,
For
for PROM.
PR1, yes. And
I will tell you.
sildenafil also was being used for some time, sir, to increase the vascularity.
I have got 5 publications on this topic. Sildenafil citrate and L-arginine. We took one patient with absent end diastolic flow from 28 weeks to 36 weeks. Okay, it's all been there on the internet. 25 milligram 3 times a day. This is called as intervention. What you are doing is evaluation. When to deliver a growth retarded baby. And here I am treating the perfusion. The cause is uteroplacental circulation. There is a deficient blood flow across the placenta because of defective invasion of cells. I am talking about late onset IUGR, not early onset. To try it in your patients, it will work wonderfully well. Okay? Your radiologist, you tell him at the IUGR, you look at the uteroplacental circulation and transplacental blood flow. And then you give sildenafil, patient will tell you there is increased movement. We have got 5 publications on this subject right now. Okay. It's one of the very, very common treatment for IUGR in our setup. So you prevent, what you do is either you don't allow the patient to deliver early and you give them the time period till 36 weeks so that maybe a growth retarded baby is born, but not a preterm IUGR. That is what is more important. Okay. Placental adhesions, we know about it. So, FET versus your ultrasound specialist has to pick up that absent this thing. This all can be antenatal steroids. Okay, I think I've got only 10 minutes now more, right? I want 5 minutes more because you started at 4:20, yeah? 4:20. Okay. So do you all give antenatal steroids?
Yes.
So Sukruti?
No, sir, not routinely, sir.
Routinely in ART patients you don't give?
I give routinely. We give.
Gestations, I
Yes,
guess.
we give routinely, sir.
We give routinely.
We give.
Okay, don't give. Okay. So do you give at 28, 30 weeks, 32 weeks?
28.
28.
Do you look at something before giving steroids?
Her blood glucose levels.
Yes, blood glucose level. Excellent. Guys, you're going great guns. Most important thing. Breastfeeding. When do you examine the patient's breast? Do you examine the patient's breast during antenatal?
28 to 30 weeks itself.
Why?
Any inverted nipples?
Why in animal models versus human models, why humans get inverted nipples more often than animal models? Sukruti?
Gravity.
Yes. Simple. Gravity and undergarments. See, 1,000 years ago, there was no undergarment. You look at the simple logic. We don't see, we don't know. And the patient is so stressed. Baby is not drinking milk, stressed. What a pediatrician does? Give formula milk. Once the formula milk is given, mother-in-law is happy, husband is happy, wife is happy, baby is sleeping. You are creating a potential diabetic patient for the future. 10 years later, the result is going to come out and going to say that obesity is going to be because of formula milk. And you also know, I also know. But do you have enough time to look at that 28 weeks? Have you scheduled a team of your nurses to look after this? Post-delivery, is there a nurses goes and stays with the patient and tells them to feed the baby? I feel that is the most important care. So how do you reduce the stress during antenatal periods in your ART patients? Harsha. Highlighting points. Reassurance वगैरह ठीक है. I agree. Tell me a unique thing you do.
That it's more like a normal pregnancy management addition to, I mean, from the patient's perspective.
No, not at all. I don't think so. Any ART pregnancy thinks is normal. Swapna?
I try to spend some time with the patient in the clinics. First thing, pregnant patients, I give priority so that I will try to counsel them, ask them, and reassure them.
What means what you talk to them means what? That is what patient wants to know. What? Sarada, you are senior. Sarada, you are senior. You tell me.
I have trained a nurse, sir, for explaining the diet schedule, because whatever we say, just tell her that you take something, whatever you want, she won't be happy. So I have trained a nurse about antenatal exercise. She will explain the patient about antenatal exercises, which she has to do regularly. The mild exercises, which I have given her a printout. And then we counsel her for her diet. Diet schedule, how she has to take, not the spicy foods, avoid all the spicy foods.
Where is the proof that spicy food will cause problem?
Like, because they complain so much of gastritis, sir, in our area. We have a lot of gastritis patients. So we counsel them regarding the diet and exercises, counsel them regarding
exercise.
Sure. Antenatal.
One side you said bed rest, one side you say exercise.
Not heavy exercises, sir. We have scheduled some mild exercises.
Okay.
And then we have a nurse trained for breast feeding.
What is most important? See, the point you have to all understand. We cannot wear all the caps. We cannot do everything on our own.
Yes.
But there are people who can do only one specific work.
Yes, sir.
And you train them for that. See, in Europe, if you have gone to the international ART centers, the consultant doesn't see the patient, doesn't scan the patient. He will see at 12:30 the reports. Ultrasound, E2, LH progesterone. Ultrasound, E2, LH progesterone. And his round is over in 10 minutes. Here you are seeing each and every patient by yourself. How are you going to tackle with this whole situation? So I like Sarda's idea, which I also follow. We have made presentations, we have made it, kept it at 12 weeks, this goes. At 16 weeks, this goes. At 18 weeks, this goes. At 22 weeks, this goes. All my patients are on meditation and medication and phone call. Once a week, all the nurses, scheduled nurses will call all pregnant patients. Post-delivery, till the feeding issue is settled down, they will keep calling every day. If there is a problem, they'll make a video call. Do you understand? Then you are managing ART pregnancies. Otherwise, cesarean section to karna hi hai. What else? Hai na? So I feel this is something very important. Galactogogus, we start at 28 weeks. We don't start later after the delivery and hydration. This is my most recommended video for everyone. Twin pregnancy. You all think twin pregnancy is so easy, no? Here is a man who's trying to dress his children. Okay, see what is happening. Just see, keep seeing it. You know, there is a lot of research has been done, and they found not even 5 years post-delivery of twin pregnancy, they found increased rates of divorce, sexual unsatisfaction, financial crisis. Just imagine anybody wants to go for only vaccination for singleton baby, it is 44,000. Just everything double for 88,000. College education, school education, see, everything is double. It's not easy. It's not easy. And this is what we are.
Sir, one thing, it's not true for all, sir.
Sada, wait. Now, see this video very carefully. What we are doing is all been given here. Please use these funds. Please read. Thank you very much for your patient hearing, and I wanted your attention on these funds which ISAR is creating. Unfortunately, in last 2 years, hardly any applications have come. You all were just now saying in the panel, cost of the patient. And here is the solution in front of you. We are giving you solutions. 50,000 rupees worth drug or 50,000 rupees to your center for IVF cycle can be provided by ISAR for a patient who are below poverty line. You just need to 0.1% to look into this and help at least 2 patients in a year. This is what we have been doing whole year, working for the cause. Okay. And thank you very much. I think we had a lovely discussion. 2 questions.
2 questions, yes, sir.
Yeah.
One is from Dr. Saroja. She says that what dose of steroid should we start, sir?
When?
In our IVF cycle.
Yeah, I give 5 milligram 3 times a day. Why so lot? Others I don't know.
When do you stop, sir? When do you stop?
I tell you, beta HCG comes positive, I will gradually step down every weekly. So by the time heart sounds come, the steroid is out.
Okay. And what is, so there's another question from Katya. Katya asks, what is the pessary that is used for preterm labor? Vaginal pessaries.
No, it's a regular infection, candid CL, candid vaginal pessary, anything. Anything. you
Betadine
can-
pessaries also, sir. Betadine pessaries.
Anything you can use. Flavor. See, betadine, when you use, the discharge will be red color. There will be problem. 2 o'clock phone call, madam. Hello, bleeding, madam. Please.
Yes.
Okay.
So another question is the sildenafil that we start off from day 3. When do we actually, up till when do we continue it, sir?
Till the time beta HCG comes. See,
Even sildenafil.
Sudha, the sildenafil citrate will work on the uterine artery, will cause vasodilatation, improve the endometrial blood flow, which is very important.
For implantation, okay.
See,
But
you
that
have to, one has to understand. See, when the ET is 7 millimeter, okay, and what is the ET which is 12 millimeter? The difference is the top portion is missing. Okay.
Yes, sir.
Right, the each side is 3.5 versus 7 millimeter or 6 millimeter. The difference is 2.5 millimeter between the two. Here is the branching pattern happens. If this branching pattern is missed, there is a high oxygen pressure at the interface, which will cause not allowing the implantation to happen. So not all thin endometrium patients do not become pregnant. There are patients who become pregnant. So what I feel in thin endometrium, we should give low dose estrogen, means the estrogen which is up to 250 levels average for a prolonged period of time. With heparin and whatever you use to improve the blood flow, and a proper Doppler ultrasound should be done with color Doppler, high density Doppler ultrasound. Okay, power Doppler ultrasound. Not the color Doppler what we use. It is a power Doppler ultrasound. And that radiologist should understand what is power Doppler ultrasound, for which I took almost 2 years to train my radiologist. Okay. For my all IUI, all IVF patients, I should send it to her. Now she's so well trained that on her reports, we decide when to terminate the cycles of FET. Now, obviously, this is the soil part. Okay. We still have to missing all the seed part. That is the embryo quality for abortion. Anything else? Good.
Questions will go to the next topic.
Good. Yeah. Go ahead. Thank
so
you
much,
very
sir.
much,
Thank you.
everyone.
Thank you, sir.
For the wonderful panel and all the panelists, thank you all for participating.
Thank you, sir.
If inadvertently, if I had pulled somebody's legs, don't feel bad. It's just for making the fun. Okay. Thank you very much. And Sulba, all the very best to you. Sulba is joined.
Yes, sir, I'm here. Thank you so much.
Okay. Where is Sulba? I can't see Sulba.
Sir, I'm here.
Where?
I'm speaking. Can you see me?
Oh, hi.
Hi, sir.
All the best. Now
Thank
this another mastermind has come to take another viva on how to use gonadotrophins. And I really feel all gynecologists should learn how to use gonadotrophins, because that is where the pregnancy is all about, not with clomiphene. Okay, bye. Thank you. Thank you, Sudha. Thank you.
Thank you so much,
Everyone.
Dr. Kedar.
Thank you, Amit. Thank you, Sukomal. Thank you. Bye.
Doctor, please stop sharing. So I'll share my screen.
Yes, I have immediately done.
Okay. Thank you so much. So I'll just share my screen. So after such a fantastic panel, so we have another one waiting for us. So would like to introduce Dr. Sulbha. So just a very short introduction for her. She's clinical director with Nova IVF Fertility in Dheri, Mumbai, and over 17 years of experience in ART, listed in top 9 IVF specialist Mumbai 2020 by Digimedia and India Today. A very warm welcome, Dr. Sulbha. Now would like to hand over the session to you so that you can share your screen.
Thank you so much for the kind introduction, Komal. Good evening, everyone, and welcome to the second session of today's webinar. I'll just start my screen sharing.
So I would like Komal to introduce all the 5 panelists too.
Madam, can I introduce them?
Yeah, yes.
Actually, Dr. Sulbha told me that
That's
she will
fine.
introduce.
That's fine.
So that's why
Congratulations. Congratulations.
I'll just mute. Okay.
Okay, thank you for that. The topic of discussion for this panel is something that forms the mainstay of fertility treatment. As Dr. Kedar has just finished saying, this is something that we all need to know how to work with when we are treating our fertility patients. So I'd like to thank ISAR President, Dr. Prakash Trivedi, Secretary, Dr. Kedar Ganla, AP State Chapter, Dr. Sudha and Dr. Sirisha. Thank you so much for the warm welcome, and MCure for their support for the session. So let me start by introducing our esteemed panelists for today. Do we have all the 5 panelists here? I did not see Dr. Prashanti.
So all 5 are here, doctor.
Okay, great. That's fine. So Dr. Anita N. She is the director of Crane IVF Center. She has done her MS in OB-GYN and her MCH in reproductive medicine and surgery. She has also undergone andrology training at the Miller School of Medicine, Miami, USA. She's been a faculty at many state and national conferences and presented many papers and posters. Dr. K. Prashanti, she is attached at the Sudha Fertility Care Center, Tanaku, and she has done her fellowship in reproductive medicine from Kerala, as well as achieved the diplomas in reproductive medicine and embryology from Singapore and Germany. Dr. C. Vijayalakshmi, she is working as a professor at Narayana Medical College, Nellore, and also doing extensive work in infertility at the Dr. C. Vijayalakshmi Fertility Clinic. She has many presentations and publications to her credit. She has trained not only in laparohysteroscopies, ultrasound, and tubal microsurgeries. She has also done her fellowship in reproductive medicine. Dr. Vignata, she is the clinical director of the Vignata Fertility and IVF Center at Guntur. She's done her fellowship in reproductive medicine from Bangalore and been awarded many prizes for posters and papers at conferences. She has also authored the book Drug Therapy in Pregnancy. And our final panelist is Dr. Anita Kola. She's the founder and director of the Pragati IVF Center, Guntur. She's done her diploma in reproductive medicine and embryology from Germany. And she has also trained from veterans in the field of ART at the prestigious IRM Institute at Kolkata. So we extend a warm welcome to all our panelists for today. I request all our panelists to kindly unmute your mics so we can start with today's session. As I introduced that the session today is on the use of gonadotropins. Now, gonadotropins, their use actually dates all the way back to the 1950s and 60s, when they were originally extracted from the urine of postmenopausal women in the form of HMH, which had a ratio of 1:1 of FSH and LH. And down the years, a lot of advances took place in the development of the originally derived HMG, mainly with an aim of reducing the LH component and the protein impurities. And now in today's day and age, we also have recombinant FSH and recombinant LH as well. Currently, gonadotropins are widely used worldwide for ovulation induction as well as stimulation in women who are undergoing ART. Now, when we want to stimulate our patients, we have a whole armamentarium of choice of drugs, which includes the oral ovulogens, that is clomiphene and letrozole, and also the injectable gonadotropins. Now, starting with the simpler treatment options like planned relations and IUI, where our aim is to get about 1 to 2 or 3 follicles at the max, and a good triple layer endometrium of 7 millimeters or more. So, Dr. Anita N., can you please tell me what are the indications or the conditions where out of this armamentarium, you will prefer to use gonadotropins for stimulation? What are the situations?
For using gonadotropins, according to the WHO Group 1 classification, hypogonadotrophic hypogonadism, they respond only with gonadotropins because they need both FSH and LH, and they cannot, oral ovulogens will not work on them. The second category will be those groups who are not responding with oral ovulogens, like with clomiphene citrate or with letrozole or with CC resistant cases. In such patients, yeah, you can start with gonadotropins, or in some trials, like in case of unexplained infertility also, some papers have showed that there is increased chances of pregnancy rate with gonadotropins than with plain oral ovulations like clomiphene or letrozole. Or even some patients with have persistently high LH values who don't respond. Such individuals also can respond well with gonadotropins. We can try gonadotropins for some people like that.
That's an excellent answer, Dr. Anita. Would any of the other panelists like to add any other conditions where you feel gonadotropins would be better compared to using oral ovulagens?
Madam, I'm Dr. Vijayalakshmi.
Yes, ma'am.
Aromatase inhibitor failure also you can give. Patient age more than 35 years and duration of infertility is more. And we don't waste time with oral ovulagens. If the long duration of infertility and age is more, then we can try with gonadotropins. And CC 2-3 miscarriages with CC failure, CC therapy also we can give gonadotropins also. And the low ovarian reserve patients and mild to moderate endometriosis. In case of mild male factor infertility, you want to do IUI, you can combine along with oral ovulagens gonadotropins.
Thank you so much, Dr. Anita and Dr. Vijayalakshmi. That is beautifully summarized all the indications where we would either start with gonadotropins because the oral ovulagens did not work, or even as first-line therapy. In cases of mild to moderate male factor, because we know that gonadotropins as compared to oral ovulagens have a higher chance of pregnancy. And in cases of endometriosis, where we want the time to conception to be lower, we don't want to spend time using oral ovulagens, because we have seen that the pregnancy rates are much better with gonadotropins. Now, this flowchart is from the ASRM practice committee that summarizes very beautifully that when you have used oral ovulagens, when you have used clomiphene, initially you start with a dose of 50 milligram. If there is no ovulation, you increase to 100. Then you increase to 150. But if there is still no ovulation, those are the cases where gonadotropins are preferred. And also when there is a thin endometrium with clomiphene, when there is 3 ovulatory cycles. Now, very often we get patients who come to us who have tried multiple cycles of clomiphene and planned relations. They come with thick files. So if they've already taken 2 or 3 cycles of clomiphene, or maximum up to 6 cycles of clomiphene, but not achieved a pregnancy, they need to be moved over to gonadotropins. And as you rightly said, hypogonadotropic hypogonadism will not respond to oral ovulagens. These are some studies which have shown a remarkable improvement in clinical pregnancy rate and live birth rate when instead of oral ovulagens, gonadotropins are used. Now, this is a very, very recent meta-analysis of last year, which included 26 randomized controlled trials where they compared oral ovulagens to gonadotropins, and they found that IUI with gonadotropins had the highest live birth and ongoing pregnancy rate, but it also had a higher risk of multiple pregnancies. Of course, there is a cost involved as well, and there has to be a strict adherence to cancellation criteria, which we will come to in our later slides. But with keeping that in mind, gonadotropins do significantly improve the live birth and ongoing pregnancy rates. So now moving on to the next question. Dr. Prashanti, can you tell us what investigations will you do before you start gonadotropins for stimulation?
Start gonadotropins for stimulation as how we investigate for the fertility for the infertile patients. In that way, we approach first. We go on with the Jeddel blood test, and then we go for the, because we are planning for the IUI, we would test for the ovarian reserve as well, and for the tubal patency also. And so when we are going for the ovarian reserve, we check for the day 2 FSH, antral follicle count, and for IUI, we do not usually go for AMH, but if we like if they have taken already many cycles of ovulations, we may go for AMH as well. And male factor also, we would investigate the basic semen analysis, that total sperm count, motility, and morphology. And these are the basic, and the hormone profile also of both of the male and female.
Absolutely. And any reason you can share with our listeners why, especially before starting gonadotropins, it's important to have a good baseline investigation done?
Any cyst, madam.
Ma'am, can I add?
Any cyst, madam.
We have to rule out TSF and prolactin levels also, ma'am.
To rule out any functional cyst also, you have to do basal scan, madam, and the number of antral follicles and ovarian volume and ovarian resistance and PSV also you can measure.
Yes.
And the size of the ovaries, whether it is a small volume, go for poor ovarian reserve or PCOS patient. To know the type of the ovary.
Yeah, these are very important parameters to keep in mind, in fact, to decide the starting dose. And we will discuss that more in detail in a while also. But mainly, before you're starting gonadotropin, see, these are patients, in many cases, you start gonadotropins in patients who've been trying already for a while. They've tried oral ovulogens also. They might have gone to other doctors before coming to your center. Now, they will come with their old reports. It's first of all very important to go through every single report in detail. What was their response to the oral ovulogens? Yes. That will help you. And mainly because now you're starting a slightly more expensive therapy for them, it is important that it's expensive. There is a potential of side effects. If you go through their previous trials, and with clomipene itself, supposing they have formed 5 or 6 follicles, you will get an idea of how they are responding. And the main thing is that gonadotropins are not a magic wand. It's not a panacea. There will still be cases which will not work. Therefore, it is important to have a thorough evaluation and a recent evaluation. Where it comes to the husband, a semen analysis should always be the first thing we do for a couple. It is the least invasive thing you can do. For a woman, even a blood test is a needle prick. For a man, a semen analysis is most non-invasive. So we don't start gonadotropins based on an old semen report, or if there has been only one semen analysis done, because we know that for a lot of men, there can be a fluctuations in count, and it's a good idea to get a recent one, to get a current status. And as you have rightly mentioned, the total motile sperm count. This is actually more valuable than the WHO parameters in deciding whether IUI would be the correct option, and starting gonadotropins and doing an IUI is justified. Where it comes to the woman, as you have already summarized, the ovarian reserve must be assessed. With just the antral follicle count is usually sufficient, and in fact more reliable than the AMH. I personally do AMH only if I see a low antral follicle count or if there is endometriosis. Other hormonal tests like prolactin and TSH, endometrial assessment. Now,
Madam, blood sugar levels and anemia, thyroid, prolactin also we have to check.
Yes, so that baseline investigation should be absolutely complete. Now, Dr. Vignatha, can you tell me what tubal patency check do you prefer? When you're starting gonadotropins, do you prefer doing a laparoscopy? Do you do a tubal patency check?
Yes, ma'am, I definitely do a tubal patency test, usually with a hysterosalpingography or a saline infusion sonography. Laparoscopy in cases where other factors need to be assessed, then only I would go for laparoscopy. Initial investigation would be HSG, ma'am.
Yeah, I think that is what most widely popularly accepted. Does any other panelist have a different opinion, or is this what most of us are following?
If there is any associated endometriosis, you have to treat all those any pelvic adhesions like that. You can go for laparoscopy along with tubal patency checking. Any correction of other associated pathology, then we can go for laparoscopy.
Yes. So what is most important is a good 2D ultrasound. When the patient comes to you in the very first visit itself, especially if you have an ultrasound machine, it's important to do it, because in one initial checkup itself, you can rule out adhesions. A lot of times you can see the ovaries are adherent. You can rule out PCOS, any other pathologies, fibroids, polyps, and most importantly, you can assess the ovarian reserve. And based on that, as the panelists have said, if you find a pathology, you may do a laparohysteroscopy instead of doing an HSG for those patients. Dr. Anita Kola, ma'am, can you tell me in your practice, what protocols do you follow for IUI cycles when you use gonadotropins?
So usually before starting gonadotropins, I assess the patient according to her previous ovulation induction cycles, and whether she is a normal responder or she is a hyper responder, or if she is a poor responder. And depending on that, I would like to assess her antral follicle count, and if the AMH levels are there, depending on that, we'll decide which protocol can be given for her.
Ma'am, do you also combine oral ovulogens with gonadotropins?
Generally, to decrease the cost of the therapy, we add oral ovulagens in the initial period and later we add gonadotropins, ma'am.
So when you use a combination, do you give the oral ovulogens first for 5 days and then you add the gonadotropin?
Initially, we give from day 2 or 3 oral ovulagens, and from day 7 or so, we add gonadotropins.
Okay. Is anyone here also using combined oral and injectable from day 2 or day 3 itself? Does anyone?
Madam, conjunctional regime we can use. First, you have to start with oral ovulagens from day 2 to day 6. From day 5, we can give gonadotropins. This is called conjunctional regime to increase the FSH threshold, thereby recruit the multifollicular development like 2 to 3 follicles. In case of unexplained infertility, like conditions, poor ovarian reserve conditions, you can go for at least 2 follicles.
There is another protocol also in which they start with
sequential
gonadotropins
protocol.
initially, and then they continue with clomiphene citrate to manage the premature LH surge. So they give from day 3 to day 6, they give gonadotropins, and then from day 7 they start with clomiphene citrate 100 mg.
Novel strategy, novel therapy.
So in that protocol, Dr. Anita, you would give clomiphene from which day to which day?
Day 2 or 3 for 5 days, ma'am. And then we do a rescan on day 7 or 8. And depending on that, we'll start gonadotropins. In IUI, actually, our aim is to have a limited number of follicles, ma'am, not too many follicles. So we can go in that with oral ovulagens and gonadotropins.
Right. So if you are starting an IUI cycle on, say, clomiphene, you have done the clomiphene for 5 days, you have given it to the patient. When do you call the patient for the first scan after that?
On completion of 5 days of clomiphene.
On day 7 or 8, we call her back, ma'am, and we can see whether the follicle is recruited. And depending on that, we can add gonadotropins.
So basically, when you call the patient after 5 days of clomiphene, what is the ideal response you are looking for on ultrasound?
Whether dominant follicle is there or not, madam. By the end of 6th or 7th day, dominant follicle should be there, no, madam. Whether the dose is sufficient to recruit that follicle to become dominant or not, we have to check. And
so what size follicle are you looking
10
for?
10 mm, madam.
Anything more than 10 mm.
So if you find after 5 days of clomiphene that all the follicles are just 6 to 7 or 8 millimeters, there is no follicle above 10, that is the stage where you will add your gonadotropins.
Yeah.
Is that what most of us are following here? Okay.
Yes, ma'am.
And I would like to see the endometrium also, ma'am.
Yes. Yes, ma'am. Please go ahead. What would you like to check? How would you like to assess the endometrium and why is it important?
Madam,
So once the estrogen level rises, we can see with the endometrial flare, ma'am. Depending on that, we can decide whether to continue the gonadotropin dose.
Yes, absolutely. We will have a little bit more about that in the coming slides, but this is a very good point.
Follicular endometrial asynchrony, we have to know if the endometrium is growing properly, if the follicle is not responding, that means inadequate follicular growth, then we have to go for gonadotropins or increase the dose.
Yeah. So when you are doing an ovarian stimulation, it is important to also keep a look at the endometrium and not just the ovarian response. As Sam has rightly mentioned, that it is an indirect measure of the estrogen level. We don't necessarily need to keep taking blood samples for estrogen in every visit. If you see in one scan that the endometrium is say 6 or 7 millimeters, and in the next scan 2 or 3 days later, you are not seeing much of an ovarian growth. They are still almost the same size as 2 days back. But the endometrium has now increased to about 7.8 or 7.9. It is showing that a growth from the previous scan. This indirectly tells you that it is responding to the endogenous estrogen being secreted by the growing follicles. And that tells you that the follicles should also catch up in growth. This is not a cycle which should be abandoned at this stage.
Yes.
Okay, so when you use only gonadotropins for IUI, Dr. Vignata, can you tell me when you use only gonadotropins for IUI, do you do that in your practice?
Yes, ma'am. In cases where there is clomiphene resistance, or in cases of lean PCO where there is higher androgen levels, we prefer to use only gonadotropins with low dose, chronic low dose. So we start them with chronic low dose step-up
So
protocol.
some of the other indications we've already covered. Now tell me, when you use gonadotropins, how do you start? From which day you start? And do you give daily, alternate day? How do you give these?
When it comes to cases where only gonadotropins, we start from day 2 or day 3 of the cycle, ma'am, and you give them daily and then assess after a week with the scan, so that if there is any dominant follicle seen, then we can continue the same dose. And if there's no dominant follicle, we try to increase the dose by 50%.
Yeah, that's
and
right.
then
Yes. So as you said that you increase the dose if there is no growth of the follicle seen. Now, when clomiphene and letrozole are followed by gonadotropins, as we just discussed, gonadotropins are started from the day after the last dose of clomiphene in most of the cases. So follicular recruitment in these cases are carried out by clomiphene alone, and sonography is done after the last dose of clomiphene to judge the follicular recruitment. Gonadotropins, when used either alone or in combination with clomiphene, do give a higher clinical pregnancy rate and a lower abortion rate following IUI. But unfortunately, there is also an increased multiple pregnancy rate. In an IUI, in fact, we can't control it. In an IVF, we can limit the number of embryos we transfer. In an IUI, if there are 3 follicles, you can even land up with triplets. Now, interestingly, this study showed that when instead of clomiphene, it was letrozole was combined with HMG, and letrozole and HMG were given together, it improved. You can see in the table above, the clinical pregnancy rate with letrozole alone is 9%, but combined with HMG is 14%. But it did not increase the multiple pregnancy rate. So this is also something worth considering, that it's not only with clomiphene, letrozole combined with HMG also improves your success rates without improving the multiple pregnancy rate.
Then the starting dose should be 5 milligrams of letrozole, madam, super ovulation.
Absolutely, that is a very good point, because 2.5 milligram of letrozole was actually what was used for breast cancer patients. And because they found that it was leading to ovulation induction, they used the same dose for fertility. But what is now considered a better dose to start with as far as fertility is concerned is 5 milligrams, not 2.5 milligrams. So when
endometrium is much better in letrozole and gonadotropin cycles, ma'am.
Yes, it is much better. So would somebody like to summarize a few points of when you use clomiphene and gonadotropins, or when you use only gonadotropins? What are the differences? What are the pros and cons?
In clomiphene and gonadotropins, there is already recruited follicles. That follicles will grow with gonadotropins, so decrease the cost and decrease the number of injections, and we are prolonging the FSH window also for the recruited follicle to grow. If there is only gonadotropins, number of injections are more dramatic, and cost another factor. And if there is any chance of cancellation, emotional burden to the financial, physical, emotional burden to the patient also.
Absolutely. So cost is also something that needs to be considered. When you combine it with clomiphene, you're reducing the number of injections, so it is a little bit more cost effective. The response is actually more predictable in a tightly controlled and monitored only gonadotropin cycle. So it is in fact easier to manipulate the dose there, and it is easier for somebody who is a beginner to use an only gonadotropin protocol compared to combining it with oral ovulogens. And also the endometrium is much better when only gonadotropins are used. Now, we were talking about giving it daily or alternate day. Some people do give it alternate day, but actually studies have shown that when it is given daily, the short life of gonadotropins is much lesser. So if you're going to give it on alternate day, the stimulation is lost every time you don't give it, every day when you're not giving it. So studies have shown that you can see there is a drastic difference in clinical pregnancy rate between giving it daily and giving it on alternate days. So when you give it, it should be daily. Now, Dr. Vijay Lakshmi, can you tell us how do you decide the starting dose of gonadotropins?
Yeah, madam. Depending on the age of the patient, duration of infertility, ovarian reserve markers like AFC, AMH, and also previous response of the patient, you have to know whether the previous response is needed a high dose of gonadotropins, you have to increase the dose. Patient age is less, BMI is less, and AFC is more, and AMH is more. then you have to decrease the dose, and if vice versa, patient age is more, duration of infertility is long, BMI more, and previous response also needed higher injections, and AFC, AMH is low, you have to give the higher dose of gonadotropins, madam.
That is very beautifully summarized. Now, when you are stimulating for an IUI cycle, can you specify what would you mean by a lower dose and what would you mean by a higher dose? And what is the maximum dose that you use in your practice in an IUI cycle?
For a poor responder, you can give up to 150 international units, madam, to 225. For normal responder, I'll start to 150 only. For high responder, starting with 7.5 to 75 only, madam. You have to assess the response and then only you have to decide. Starting dose should be like this, and depending on the AFC, MH also, all the criteria. If she is a high responder, go with 37.5 to 75. Poor responder, go with 150, and normal responder in between 112.5 also you can start with.
Absolutely. So if usually the maximum dose in an IUI cycle should ideally be not more than 150. Because if this is a poor responder patient who is requiring 225 just to form those 2 or 3 follicles you need in an IUI, we need to keep in mind that an IUI is a basic ART. It is not an advanced form of
should
ART.
counsel her for an IVF instead of when she's
Absolutely.
not responding very well for an IVF
Absolutely,
cycle.
Dr. Anita, rightly said. So these are patients who actually require IVF, not IUI. And within IUI, no matter what you do, your success rates are going to be about 15 to 20%.
20%.
Yes. So if you are using such high doses, they are spending a lot of money and they are poor responders, their chances of success will not even be that much. So 75, 150 is the highest dose we start with. There are a couple of charts and nomograms that especially beginners can follow. So for example, this one has where you check the number of antral follicle count and the patient's weight to decide what should be the starting dose. Now, for example, if you see an antral follicle count of 15 and the patient's weight is 65, the ideal starting dose is 75 units. So once you get used to doing these stimulation protocols, you don't need to refer to these. But for somebody who's just wanting to start, these are very good things to refer to and get a basic idea. Similarly, there is a Sono scoring system that gives points between 1 to 5 based on age, BMI, antral follicle count, ovarian volume, stromal RI, and peak systolic velocity. And based on that, what score you get for your patient is how you should decide what the starting dose should be. Because with a high score, these are patients who are likely to be hyper responders and require a much lower starting dose. Dr. Anita N, can you also tell us a little bit more about what are the step up, step down, and chronic low dose step up protocols?
No, step up and step down protocol. Now, step up protocols is that you start with a lower dose, like around 75, or chronic low dose means you start with even 37.5 to 50 international units per day. And then you do scans every 5 to 7 days, and then you increase it. Either you double it or you increase it by one ampule, like 37.5 every week. This is like chronic step-up protocol. Usually we plan for people who are having like a PCO, when you don't want like hyperstimulation of the ovaries. So that initially you start with a low dose and then you gradually increase the dose. And when you do a scan and when you see the dominant follicle and whichever value she's responding well, you continue with that amount of gonadotrophins and continue till her trigger. In case of step down protocol, like you start off with a higher international unit, like around 150 mg, and then after 5 days you do a scan, and then if she's responding well, if you see a dominant follicle, then you can step it down to around 37.5. You can keep stepping down till the administration of the HCG trigger. And this like in step down protocol, you can start with the little poor responders because initially you want to recruit more number of follicles, and once they reach the dominant follicle stage, then they will be almost most of the follicles will be independent of the gonadotropin. They start growing, so that time you can start stepping down the gonadotropin usage also.
Very beautifully explained. So this is a more physiological protocol, the way the nature actually works in the natural cycles. And only thing is that because at the recruitment stage, you're using a slightly higher dose, you can land up with more follicles. So this is an ideal protocol for IVF. And this one, as you rightly said, especially for anovulatory PCOS women, very, very gradual increase in dose, because these are the women where it's like walking a tightrope. You use a lower dose and then you go on for 20, 22, 23 days and there is no follicular development. Although we've had cases where they showed the dominant follicle was ready by day 22 or 23 also. So it is very important to be patient for us as well and for the patients as well. Most of the times we start losing patience even if the patients are not. And
Maximum duration is 35 days, madam.
yes,
Maximum duration of stimulation.
yes, it
Is
can
it
take
possible,
that.
madam, they can come up to 40, 35 days? In
Yes,
chronic care, that's the problem.
It can take that, and then they start worrying that, when it's been 27, 28 days, they think up to period aa jayega. So it is important to explain that also to them, that why it can't come. Your follicle is not even ready yet. So the period is not about to come. And the main thing is, like you said, it is to be patient, to go gradually, because the minute you try to go a little faster, these are the patients.
More of follicles will be recruited and the multi-follicle development will be there.
Yes. Okay.
And one more thing, recruiting only one follicle, madam, for such how many days stimulation. If you want to do IUI also, 50% chance. Our aim is in IUI minimum 2 follicles. That is one more thing. With so much gonadotropin, so much expense, all those time consuming, everything.
Yeah, that's right. So now coming to the next question, Dr. Prashanti, can you tell me which gonadotropin do you prefer and why, HMG or FSH? Dr. Prashanti, we are not able to hear you.
Yes, ma'am. Now, ma'am, for IUI cycles, I would definitely prefer HMG, madam, because the success rate, how much ever we do, it is going to be 10 to 15%. Only if we go for Antag, then it may raise to around 20 to 25%. So, and second thing is, only in few cases I would go for FSH, like in PCOS. And in such cases, I would go for FSH. And second thing is, even if you go for an Antag also, the cost is going to go up. It will go up to around 35 to 40,000. So because in our scenario, we have to see the cost effect as well as we have to balance both. What actually the realistic thing which we are going to tell to the patient, how much it would cost and what is the success rate. All this, when we weigh all these, I would definitely prefer to go for HMG in IUI cycles, except for few exceptions.
The ovulation rate and pregnancy rates are almost similar, madam. That's why
HMG and FSH or clinical pregnancy rates are similar, ma'am. So many studies have been there. Even in IVF cycles also, the clinical pregnancy rates are almost similar, whether we use HMG or recombinant FSH.
I am so happy in the panel today that everybody is giving such textbook perfect answers, that this is exactly what the literature says. And these are very, very good points for the people who are signed in today to take home, because this is the ideal way of practicing. So let's just take a quick poll with all the panelists. HMG or FSH? Does everyone agree? Dr. Anita Kola, ma'am, what do you use?
Ma'am, I use HMG and FSH also, ma'am. In cases where the LH is very high, some cases I give FSH in the initial period, ma'am.
Okay.
In such cases.
In PCOS with
very high LH levels. Because of the cost factor, we go with the HMG, ma'am.
Yeah. Dr. Vignata, what would you prefer to use?
Mostly I prefer HMG, ma'am. As said, in PCO cases with high androgens and high LH levels, I would go for FSH.
Dr. Vijay Lakshmi?
Yeah, madam. Most of the times HMG in special conditions like PCOS, that too lean PCOS, I'll go for recombinant FSH.
Dr. Prashanti has already explained quite a lot in detail. Dr. Anita N, you also, what do you prefer to use?
Mostly HMG, ma'am. First is HMG preference only, except for exceptions only.
So yes, so I think the entire panel agrees, and I agree too with my personal experience that HMG and FSH both work very well As we've discussed, IUI is got a limited success rate. We should not make it unnecessarily expensive, because then if patients have gone through 1 or 2 cycles of expensive IUIs and not conceived, they may not even have enough funds left to undergo the IVF cycle. We try and keep it as simple as we can, as inexpensive as we can. There are a few cases of PCOS who have not responded to clomipene, not responded to HMG, who respond beautifully to recombinant FSH. But in those cases with the very, very high antral follicle count, we start with very, very low doses of recombinant FSH, just about even 37.5. And that is why the pen devices are useful, because with a pen device, it's easy to get that 37.5 dose. When you use a 75 units vial of HMG, you cannot use 37.5 and keep the rest for the next day, because this is a powder and water that needs to be mixed. And once it is reconstituted, it needs to be used immediately. Yes, it cannot be kept for the next day. So this very, very large meta-analysis that included 42 randomized control trials, almost 10,000 patients, where they compared the outcomes of using recombinant FSH versus urinary FSH and HMG for IUI cycles. And they found absolutely no difference in live birth rates, OHSS, any other outcome. And in fact, they concluded very remarkably that since all gonadotropins are equally effective and safe, no further trials are warranted to find this out. This is proven beyond doubt. The choice of gonadotropin should depend on availability, convenience, and costs. The Cochrane database system review also agrees with whether you use HMG or FSH, HP preparations or recombinant, there is no difference in live birth rates or OHSS rates. For IUI, HMG should ideally be preferred. So now that brings us to this table where we can see the differences in a tabular form. HMG is more cost effective, recombinant FSH expensive. With HMG, although the response can be a little unpredictable, with FSH it is more predictable, and it is difficult to manipulate the dose. As I said, when you reconstitute it, the pen devices with FSH are easier to monitor. Now, how do you monitor the cycle? Do you do it with ultrasound? Do you do hormonal tests? Anyone in the panel who would like to answer this question?
Yeah, madam.
Routinely an ultrasound. Usually hormonal investigations, I'm not preferring for an IUI cycle because it would increase the cost for the patient. Regular follicular monitoring would be more than enough for an IUI cycle.
Yes, that's right. So
in case of any hormonal investigation you want, if there is any cyst, you want whether it is functional or not, you want to continue the stimulation. To about that, you have to do E2 levels. Suppose there is a hyper response, you want to convert it into IVF cycle, also you can do E2 and LH levels. And the previous no response like that, you have to assess the patient. And the hormonal investigations, if there is any cyst, you have to rule out hyperprolactinemia also, madam.
Yes. So if you find a functional cyst and you want to check the E2 level, what cutoff of E2 level do you take to decide whether this is a cyst which is secreting estradiol or not?
If it is more than 50 picograms per ml, it is a functional cyst.
Okay, that's right. So the ultrasound is the mainstay of follicular monitoring. We do a baseline ultrasound, we repeat it on day 5 or day 6, and then every 2 to 3 days. As we mentioned, keep a watch on the endometrial thickness. Also, as Dr. Vijay Lakshmi has rightly said, E2 in conjunction provides an accurate gauge in certain cases where there is either no recruitment or when you're finding too many follicles that are growing. So this is the same thing presented in a tabular form. Ultrasound is usually enough, and even to find out if the follicles are likely to respond or not, checking the endometrial thickness and morphology alone should be enough, but you can supplement it with E2 levels if required. So now, do you do the follicular monitoring yourself, or does a radiologist do it for you?
We do
it
ourselves, ma'am.
Ourselves only.
We do it ourselves.
We will come to know everything about the.
Yes. So now, ideal thing is do it yourself when you're doing a follicular monitoring. Radiologists, they are very, very good in their field in radiology, but I feel that there are a few things fertility related that they may not be very aware of. So if you don't have an ultrasound machine in your setup and you are sending your patients to a radiologist for monitoring, there are a few things that need to be kept in mind. Anyone on the panel, can you tell me the few things that should be conveyed to the radiologist that may be missed?
Number of follicles recruiting, how many dominant follicles are there, subendometrial flow, endometrial blood flow, perifollicular flow, RI and PSV, everything we have to ask the radiologist, madam, to mention.
Yes.
And sometimes they don't have that much time during follicular study. They will spend only hardly 1 minute or 2 minutes, just follicle size and endometrium thickness only they will tell. So
Yes.
suppose you go on that, you stimulate, sometimes hyper response may result in OHSS also.
Yes, that's a very, very valid point. So if a radiologist is doing your monitoring, do have a good detailed discussion with the radiologist and coordinate after every scan with the radiologist to find out what exactly they have checked and measured. To start with, it is important to do a transvaginal scan only, especially when you are doing the baseline scan, because many a times follicles that are very small will not be picked up on an abdominal ultrasound, and then you will not get a correct idea of the antral follicle count and hence what should be your starting dose. Secondly, many of them in a routine ultrasound, when you see pelvic ultrasound, in almost all cases, the antral follicle count is not even mentioned. So this is something that we must ask them specifically to check and also to mention it. I had a case where there was a radiologist friend of mine, his sister-in-law came down for IVF from the US. Her AMH was 0.1 in the US, and she didn't want to do IVF there. It was too expensive. When she came here on day 2, she said, my brother-in-law is the radiologist, so I'll do my baseline scan here. And the radiologist told me there are 10 to 11 antral follicles on each side. I could not believe it with an AMH of 0.1. So I said, okay, then we'll start with a dose of 225 for the IVF. But when I saw her on day 5, I had a doubt. So I said, let me check on day 5. There was one follicle in the right ovary, which was 12 mm. There were no other follicles in the right ovary. The left ovary had no follicles at all. So somehow I feel that when they are training for the radiology or when they are doing the scans, probably antral follicle count is something that we as fertility specialists are more well versed with. So this is something that either we check with a radiologist who knows very well how to check it, or then we tell them that this is something that needs to be checked on transvaginal scan and it cannot be missed. And when you start the monitoring, when you start the stimulation, as you can see in this diagram, there are a few follicles that are larger. Sometimes the radiologist will measure the leading follicle and then write multiple small, or measure 1 or 2 and then just write multiple small. But it is important to get the sizes of all of them, because as your stimulation progresses, you'll suddenly have an explosive response because the smaller follicles were not mentioned. So this is a bit about when the radiologist does your follicular monitoring. Now, coming to the special conditions like hypogonadotropic hypogonadism. Any special things to be kept in mind? This is also anovulatory. PCOS is also anovulatory. So how do we stimulate? How do we go about it?
We cannot use oral ovulations in this case, ma'am. We have directly start with HMG preparations because those cases are deficient of both FSH and LH.
Absolutely. Yes, so
narrow FSH threshold and window should be maintained. Sometimes it may go for hyper response also. You cannot give GnRH agonist in these cases. No intact HPO actors. You have to give HCG only. So you should be little cautious. Titration of the dose, maintenance of the dose is very important in hypo condition.
Absolutely. So the things to be kept in mind, the oral ovulations will not work. When you are using gonadotropins, when you can't use only FSH because they are LH deficient as well. LH is required for the androgen activity, which will be the substrate that will be used. So FSH and LH both need to be given. When you use only FSH preparation, sometimes you need to use very, very high doses. So the main thing even with these patients is that we need to be patient because sometimes the stimulation can take quite a long time. Okay, so now Dr. Prashanti, can you tell us when do you trigger when you use gonadotropins for IUI cycles?
Yes, ma'am. I do a transvaginal scan and one of the dominant follicle has reached 18 mm size and endometrium is more than 7 mm. Then I give a trigger. Usually I don't do any Doppler, but some people do Doppler. and they check for the PI and the perifollicular blood flow as well.
Okay. And everybody else agrees this is how you decide the trigger point? Okay.
Madam,
How does this differ?
18 to 19 you can wait, madam. For IU, 18 to 19. For IVF or 18 mm. Sometimes Jelly lab may correct, madam.
In gonadotropin cycles, usually we can trigger at around 18 mm, but in oral ovulation CC cycles, we can
More
wait
than,
20 mm also.
20 mm, more than 20.
Yes, that's absolutely right. So when you use the oral ovulogens, you need to wait till they have reached 20 or 21. When you combine with gonadotropins 19 to 20, when you use only gonadotropins slightly earlier. Can anyone tell me why is this difference? Dr. Anita N, can you tell me?
Because when you're using gonadotropins, the sensitivity of the follicles and the maturation of follicles occurs earlier than like when you're using an oral ovulation. So when it is around 17 to 18 millimeter, we assume that they have a mature grafting follicle inside, and so we can trigger them in that stage.
Absolutely. So two reasons. One is that when you use gonadotropins at a smaller size between 17 to 18 millimeters, already you can expect an M2 oocyte. With the oral ovulogens, it occurs later. And the second thing is the endometrium as well, because with clomiphene it's a little thinner. It will require 1 or 2 days more to proliferate enough and reach a good thickness. Okay. So now I'm going to present to you a case scenario. You have started IUI with 75 units daily, right from the first or the second day of the cycle. You do the scan after 5 days, all the follicles are small. They are all 9 to 10 millimeters. Day 7, it is still the same situation. Then you finally decide to increase it to 150 units. But when you check after 2 days, there is still not much growth in the follicles. You don't want to increase the dose further. You still want to see for some time. So you call the patient 2 days later and this is what you see. So now what will you do next? Anyone who would like to answer this question? Dr. Prashanti, what will you do next?
Madam, I'll give ANTAG, madam.
Okay. What are this is a case of hyperstimulation.
Hyperstimulation.
And initially I would
Madam, if the patient is affordable, I will convert the case if there is any hyper response to IVF. Otherwise, I will cancel the cycle, madam.
Yes. So your two options are to either
First of all, while giving gonadotropins, you have to counsel the patient what is the cost and what are the consequences you have to face. These are the two things, and documentation is important.
Very, very important points, very valid take-home messages that prior counseling, especially in an expected hyper responder, is very important, because this is a scenario that they can come to face. And then suddenly you tell them you have to cancel after taking so many days of injections, or you have to convert to IVF. If they are not counseled beforehand, they may not be mentally prepared. If they decide to cancel the cycle, what advice will you give? Dr. Anita Kola, can you tell us, ma'am?
Ma'am, I would like to give few days antagonist, ma'am, to decrease the size of the smaller follicles. And if she's going to OHSS, I would like to give Cabergoline.
Perfect. Anything else that you would like to add? Any other
advise them barrier contraception. We can
avoid intercourse. You have to explain. And the symptoms, any symptoms, you have to advise her to come back. And one more thing, high protein diet.
Yes.
You have to,
hydration.
And plenty of fluids, yes. Dr. Vijay Lakshmi, Dr. Anita N, and Dr. Prashanti, those are precisely the additional things we need to tell them. Either avoid intercourse completely, or they can use barrier contraceptives. Although with such hyperstimulated ovaries, I'm not sure how comfortable.
Sometimes pain may be there, some torsion, fear of torsion also may be there, madam.
Yes. And then you should ideally call her for follow-up so that you can monitor.
You have to give progesterone also, madam.
We can also give
levels
for withdrawal. Yes.
We can also give letrozole, ma'am, to prevent OHSS.
Yes.
Ideally is to convert her to IVF cycle, ma'am.
Can convert to
IVF. If the patient is not agreeing, then you have to cancel, madam.
Yes, absolutely. Ideal is to convert to IVF. Absolutely right, because here is a patient who has just taken a few days of a slightly lower dose of gonadotropin and already formed a response which we ideally want in an IVF cycle. Not just that, an IVF has got a much higher success rates. But as we discussed, was the patient counseled beforehand? Then they may be willing for it. If this is something we are suddenly telling them, it may be a little difficult for them to accept financially and psychologically. The second thing, yes, there is a cost implication and also the facility. Now, if you have an IVF lab in your own clinic, if you do IUI and IVF, it is much easier to convert a hyperstimulated IUI patient to an IVF. However, if you are doing IVF in your setup, but you don't have the facility for IVF, when you are starting stimulation for an expected hyper responder, you should already coordinate with an IVF clinic, an IVF colleague that you're close to, that you know well, and keep them posted that I'm stimulating this patient. In case she hyperstimulates, we will bring her to you for IVF so that the cycle can be salvaged. And the antagonist should be added in at this case when you see on day 13, day 11, whenever you see that the follicles have now grown, they've reached around 12, 13 millimeters, you start the antagonist. Now, how will you prevent OHSS in such a case?
In such
So E2
cases,
and LH levels, madam.
Madam, in such cases, we give antagonist and continue low dose gonadotropin till the follicle reaches 18 mm. And to avoid OHSS, we give agonist trigger, ma'am. And we retrieve all the follicles. And if there is risk of OHSS, we freeze all the embryos, ma'am. And we can do segmentation IVF, ma'am. Segmentation. We can freeze all embryos and transfer in a later.
And from the day of
ANTA can be continued even after the oocyte pickup. ANTA can be continued, which will help to prevent the OHSS.
Cabergoline can be given.
Yes, absolutely. So these are the things we do. We give a agonist trigger. We freeze all the embryos. You can add antagonist after the pickup. You can also add cabergoline after the pickup. If these things are followed, and of course, then the other things like plenty of fluids, hydration, you tell the patient once again 5 days, 3 or 5 days after the pickup to monitor her. If you follow this,
albumin, it's
high protein diet.
Albumin is debatable, but some people do give it. And if you follow all these, steps quite strictly, you will not have any patient who ends up with the moderate or severe OHSS. Mild OHSS has now been removed from the classification because a lot of patients have that as a part and parcel of normal IVF. So there are studies which have shown that when an IUI cycle with a hyper response is converted to IVF, the pregnancy rates are as high or even higher than a pre-planned IVF cycle. And this study also, where there were PCOS patients who were initially planned for IUI but converted to IVF because 50 of them had a hyper response, they found a clinical pregnancy rate, clinical pregnancy rate of 28.5 in a fresh embryo transfer and 38.1% with frozen embryo transfer. So this is a good option if the patient is prepared mentally and financially. So now, Dr. Vignata, can you tell me what are some of the other difficulties you can come across when you are using gonadotropins? And are there any other situations where you may need to cancel your cycles?
Other difficulties we may face is usually multiple pregnancy. We have to explain the patient because with IVF, we have a chance of single embryo transfer, but in this case, we don't have that option. So that would be counsel for the patient. And sorry, ma'am, what is the other question?
The other question was, what are your cancellation criteria? What are the other conditions where you may need to cancel a cycle?
If there is any response or any hyper response, also you have to cancel, madam. On each side, more than 4 follicles. On each side, with E2 levels more than 3000 picograms, you have to cancel. Or 2 to 3 follicles with E2 levels more than 1800, also you have to cancel. And
yes, that is exactly what the recommendations are, that 3 to 4 follicles with E2 levels of some studies say 1200, some, as you rightly mentioned, say
1800.
Our aim is mainly like take home baby, madam. Live birth and take home baby should be our aim. So that's why we have to plan according to that.
Yes.
According to the age of the patient, we can go even up to 3 to 4 follicles if she's above 35 years. Now. She's younger, we can.
It's better to go for 2
follow
follicles.
around 2 to 3 follicles in IU.
Yeah, see now those are papers, the textbooks, they all mention that more than 2 or more than 3 follicles, it should be cancelled. We've all faced situations in our practice where there are 4 follicles and we're not really sure now, should we cancel, should we go ahead? After the patient is, especially on gonadotropins, after the patient has spent all that money, some of them may not be very, very affording. You can go ahead with the IUI, but you really need to counsel the patient that there is a possibility of a multiple
pregnancy.
Pregnancy and late OHS also, madam. OHS also, if the patient conceives, late OHS also become troublesome condition.
Yes, absolutely. So now, how do you tackle a premature LH surge? Dr. Ignatha, would you like to tell me, do you use antagonist in your practice?
Ma'am, in routine IUI cases, I don't use antag, but then if I have seen the previous response where she has a premature LH surge, then I would prefer to go for antag in IUI, ma'am. But then, sorry, but then routinely we are not doing LH levels, I mean blood testing of LH. So depending on the patient response from the previous cycle, I would consider antag, ma'am.
Yes, absolutely. So now one thing is what the theory says. Theory says that LH more than 10 accompanied with a rise in progesterone is a premature LH surge. Like you absolutely rightly said, we don't monitor these hormones for all our IUI cycles. But if there is an incidence of premature LH surge in almost 25 to 30% of stimulated IUI cycles. So what we go by more is that a previous cycle where there has been a premature rupture, you've done the scan on day 8, you find follicles are 13 to 14 millimeter. Day 10, they are 15 to 16. And then day 12, they've already gone before you could even trigger. So what would you do in such a case?
We start off with the antagonist in such a case because
the next one.
The next cycle.
In the next cycle,
Madam, can we give clomiphene, madam? Do you have any experience regarding that after gonadotropins to counter premature LH surge? Can you give clomiphene, madam?
You can give it, but the point is that in most cases you are using gonadotropins where clomiphene has already failed in the past.
Yeah.
In those cases,
Once follicle reaches around 13 mm, then we can start antag in the cycle where we have started IUI, noting the previous response, ma'am.
Yes.
So usually, ma'am, 1/4 of all these gonadotropin cycles have a premature LH surge. So adding antagonist is ideal at least after 14 to 15, but as such, it increases the cost of the IUI treatment.
Yes, not necessary for routine practice to add anta.
Ovarian reserve patients.
Yes.
All those patients you can give antagonist, madam.
Yes. So
avoid weekend inseminations.
Yeah. So exactly. So if you cannot come on a Sunday and call your whole team on a Sunday, usually with an IUI there is quite a bit of flexibility. But if you feel that she may rupture, then you can give 1 or 2 doses of antagonist. Other indications where antagonist works, as we have already discussed, that if there has been a premature rupture in a previous cycle and we want to prevent that now, when there is a PCO subpopulation or when there is an expected multiple follicular development, some people prefer to add antag from once they reach 13, 14. These are also patients who may end up getting converted to IVF. And these are also patients which are likely to have a premature LH surge. And then there are older patients. What happens in them is that when you stimulate them, the follicle is ready too soon. By day 7 or day 8, it is already of a mature size. But it may be too soon to do an IUI because the endometrium
will not be ready.
May not grow.
So in these cases as well, the antagonist will help. The pregnancy rates when you combine gonadotropin with antagonist are ideally actually much higher than the pregnancy rates without antagonist. But because of cost implications, it's not added ideally for all patients. So now, Dr. Anita N, can you tell me about the luteal phase support? When you use gonadotropins in IUI, do you supplement with the luteal phase?
Yes, I do supplement because when you're using gonadotropin, there's supraphysiological elevation of estradiol and progesterone. So progesterone levels will be low. So your luteal supplementation is a must for all patients undergoing IUI with gonadotropin cycles.
So what do you use? Let's hear from all the panelists. Dr. Anita, and what do you use for luteal phase support after gonadotropin and IUI?
After gonadotropin, I use micronized progesterone.
Orally, vaginally, rectally, how do you give it?
No, I give them vaginally.
And what dose do you give?
I give them 200 milligrams daily.
Once a day. Okay.
Once a day.
And how long do you continue it for?
I continue till heartbeat.
Okay. Dr. Prashanti, what do you use for your luteal phase support?
I give a vaginal micronized progesterone, 200 milligrams BD, ma'am.
Okay.
If I use an antagonist in the cycle, then we have to give a little higher dose of progesterone, I feel.
So then what do you
luteal support? I would like in very few cases where I use an antag, Duphaston,
orally you add
dydrogesterone 10 milligrams, oral BD, because vaginal I would prefer to give only micronized progesterone. I would prefer to give only vaginally. If at all I would like to add oral, if the patient is complacent to take oral, I would like to go for dydrogesterone oral, 10 milligrams TID.
Some of them
continue up to 12 weeks, madam.
Yeah, continue up to fetal heart 7 to 8 weeks.
Dr. Lakshmi, what do you use? Oral, vaginal?
Vaginal progesterone, madam, micronized vaginal progesterone, 300 milligrams BD I am giving them.
Okay. Dr. Vignata, what are you using?
Routinely, I'm using vaginal progesterone 200 milligrams BD, ma'am. In cases where I find there is an immunological cause, then I would go for oral dydrogesterone, 10 mg TID thrice daily.
Patient is having any white discharge, any genital infection, I'll go for oral or intramuscular.
So genital infection should ideally be treated anyway before you do the IUI. Also, once
Yeah,
you
madam.
do vaginal progesterone, a lot of them call up frantically saying that I've got white discharge. I
White.
think I have it.
And irritation due to discharge. Some people don't take properly vaginal progesterones.
Compliance is a must for vaginal
So we have to
filtration.
counsel them that it is only the drug which is leaking out. They can use
That might be the cause for failure sometimes. Improper luteal phase support due to not proper using vaginal progesterone.
And those are the cases where the oral dydrogesterone may be helpful. Dr. Anita Kola, ma'am, what would you use for luteal phase support?
I routinely use vaginal progesterone, ma'am, but if the patient is not comfortable, I use oral dydrogesterone, and sometimes in cases of recurrent pregnancy loss also, I add oral dydrogesterone, ma'am.
Okay. Is anybody using any kind of adjuvants to support the
L-arginine and some few cases.
L-arginine you use for in which cases?
In luteal phase support, madam, to increase the vascularity by releasing nitric oxide.
In all cases of IUI?
Ma'am, in cases where there is the endometrium is thin, we would like to add even estradiol in the luteal phase support, ma'am. Though there is no evidence that there is a clear benefit of high pregnancy rate, but where the then we would like to add L-arginine and also estradiol in the luteal phase, ma'am.
Okay, and is anybody also adding estradiol in the follicular phase? Because I have seen some prescriptions.
Madam, due to thin endometrium, in case of CC stimulated cycles, once the follicle reaches 17 mm, then only you have to start the estradiol. Otherwise, it will have negative feedback and no growth of follicle.
Absolutely. This is important to remember. So the estradiol should be added only once the follicle has reached a certain size.
Start it in follicular phase. Please continue it in the luteal phase. Also, estrogen priming progesterone is important for to act.
Yeah. Anyone using any HCG or any agonist for luteal phase support?
For IUI, not.
No, not using.
Okay. So the basis for why luteal phase support is important when gonadotropins are used, because there are multiple follicles at times and multiple corpora lutea that get formed, which initially increase higher amounts of estrogen and progesterone, supraphysiological levels. This causes a negative feedback to the pituitary, which has a drop in LH and FSH levels and lack of luteotropic support. So there's early luteolysis, and therefore luteal phase in gonadotropin cycles is usually inadequate and varies with the degree of stimulation. Luteal phase support is important. Now, this is a study which has shown that meta-analysis in 2017 with 4,000 cycles, where they found when progesterone was added, the pregnancy rate with IUI was much higher. So now we are coming to the end of this discussion. And would someone like to summarize, when you use gonadotropins for IUI, what take-home messages would you like to give to the audience? This is the ASRM practice committee, what they recommend.
Madam, it is a costly procedure by using gonadotropins. So our aim is early to give pregnancy to the patient and take home baby. Live birth also our aim. So in case of anovulation, our aim is monofollicular development. In case of ovulatory patients, superovulation. Sometimes controlled hyperstimulation also in ART. So be cautious while using gonadotropins, and what are the consequences and complications you have to explain to the patients, and everything should be documented. That is the main important thing. And risk of multiple pregnancy, OHSS, cancellation and conversion to IVF. These are the things you have to tackle while giving gonadotropins, and everything should be documented.
Yes, that is, I think, summarized.
Pernicious while using the gonadotropins.
Anyone else would like to add anything?
One more point, we have to strictly follow the exclusion criteria, ma'am.
Yes.
If there are too many follicles, we should not go ahead with the IUI. Otherwise, we have to convert it to IVF or cancel the cycle, ma'am.
Yes, so for that, the first important thing is patient counseling. Even before you're starting the cycle, the patient should be counseled about what can happen when you're using gonadotropins. There may be an excessive response, the cycle may need to be cancelled. There may be no response, the cycle may need to be cancelled even in those cases. So the ASRM practice committee, what they recommend is that whoever is doing gonadotropin stimulation should have at least some degree of training or experience, or then do it in coordination with somebody who can guide you at each step how to do it when you are initially starting off, till you have the experience enough to handle these cycles on your own. Monitoring, ideally, you should do on your own. When you are using gonadotropins, the aim is monofollicular development or maximum 2 or 3 follicles. Now, this can be difficult to achieve, but it is important to reduce your multiple pregnancy and OHSS rates, although those cannot be completely eliminated when you use gonadotropins. And gonadotropin should always be started at the lowest possible dose that can give you a response, that is 37.5 or 75. In some cases, you may need a slightly higher dose. Cancellation criteria, as we have discussed, and luteal phase support needs to be added. This is a practical guide. When the patient comes to you on day 2, day 3, or day 4, you do a transvaginal scan to rule out an ovarian cyst. E2 levels, we don't mostly do it. Assess the dose and the type of protocol, as the panelists have very well explained during this session, especially if there has been a previous case of a hyper response. Also based on the patient's age, AMH and AFC, and the type of ovary, whether it is PCO or non-PCO. A few more practical tips. Proper monitoring facilities should be available. Start with softer stimulation protocols. Get very well versed with one protocol before you try others. Be careful in increasing the dose. Step up by 37.5 at a time. Multiple dose vials are helpful. And the response may be sudden and explosive once the threshold is crossed. So give the higher dose for at least 3 days and monitor again. No matter how careful you are, OHSS is likely, you should be ready to tackle it. Remember that the response varies from one patient to another patient. A few other precautions that need to be kept in mind when you use gonadotropins, that cold chain must be maintained. Even when the patients take the gonadotropins home with them, we tell them keep it in the fridge, not in the freezer and not in the door of the fridge, because it keeps opening all day. There is a lot of temperature fluctuation, and you can give subcutaneous forms because gonadotropins are injectable, and a lot of people have apprehensions about it. And as we discussed, that once they are reconstituted, they should be used immediately. So that was pretty much all about today's discussion. Would any of the panelists like to add any more take-home messages for the audience? Anything from your side? Any practical points from your experience?
Ma'am, in chronic anovulatory patients, it is ideal to strictly follow chronic low-dose protocol, ma'am. And in cases of ovulatory patients, we can delay start of gonadotropin is ideal, ma'am. And in cases of frequent cycles, poor ovarian reserve, we can extend the follicular phase. That is, we have improvement in such cases, ma'am.
Yes.
For beginners, you should be judicious and plan low dose step-up protocols are ideal. For experienced ones, step-down protocols are ideal. But while starting gonadotropins, be aware of the complications and management also before starting gonadotropins.
I think that sums up today's discussion pretty well, what we have discussed about the use of gonadotropins. Thank you so much to all the esteemed panelists. I thoroughly enjoyed that discussion. And I'm sure the audience is going back home with a lot of take-home messages.
We'll expect many more webinars from you, madam.
Thank you. Thank you.
Thank you.
Thank you so much, ma'am. Thank you so much.
Dr. Sudha, you're on mute.
We have few questions from the audience, Dr. Sulba. The one is Dr. Deshmukh. With severe PCO, BMI 22 and a dosage of 75 international units for 7 days and 7 follicles on each side, how do we proceed? That question has been very clearly answered. With 7 follicles on each side with a low BMI and all, how do you proceed? That's the question.
Okay, Dr. Anita Kola, would you like to answer?
If the follicles of same size and if there are too many follicles, as we discussed, either we convert it to IVF or we have to cancel the cycle, ma'am. We can convert it to IVF. We can continue the low dose of gonadotropin and add antagonist once the follicle reaches 14 mm.
If the follicles are more than 11 mm of 6 follicles also will cause OHSS. So patient affordability, and if she wants to convert, she can afford, we can convert it into IVF or otherwise cancel it strictly.
Or we can add antagonist and observe, ma'am. If the follicles regress and to the end, if there are only 3 to 4 follicles, we can go ahead.
Usually, if they are of a size of 11 to 12, there is a chance that they won't grow further. But once they've reached about 13, 14 millimeters, it's unlikely that they will regress.
They will start growing.
The other question is, on what day E2 should be checked?
Dr. Vijay Lakshmi, would you like to answer?
If there is multifollicular development, if you on gonadotropins, you have to check it on day 8, madam. Once the follicle reaches 14 mm, there is.
Supposing you have, Dr. Vijay Lakshmi, if I can just add a little, extend this question. When you're seeing no recruitment of follicles after stimulating for many days, do you also check E2 levels at that time, and how much should they be to tell you that it's worthwhile continuing, or should it be abandoned?
Madam, if it is not less than 50 picograms, or growth of the follicle is not there and growing less than 125 picograms of E2, there is no follicular growth, proper follicular growth. Or otherwise, each follicle should be around 150 picograms per ml estrogen secretion.
At that
time of
each follicle actually secretes around
mature follicle 200 picograms.
200 picograms. So depending on that, we
there
have
is less than 125 picograms per ml of each follicle. There is no proper growth.
No, but if you are not seeing any follicles at all, supposing you're giving 75 units and after day 5 all small, then after 2 days again all small, you make it 150 after 3 days.
And sometimes even high E2 also, you won't recruit follicles, then you add antagonist. Then only you can recruit follicles.
Ma'am, in such cases, we have to observe the endometrium, ma'am. If the endometrium, it shows that opening sign, we can continue with the gonadotropin, ma'am.
Yes, absolutely.
Any follicular endometrial asynchrony, there is defect in the follicular growth. If the endometrium is growing, inadequate follicular growth, what might be the cause? You have to see any endometriosis.
So in most cases, a well done ultrasound monitoring is enough. Even the literature says that combining it with hormonal monitoring is not always required. But in some cases, you may want to do E2 levels just to get a confirmation of what is the underlying status. Dr. Sudha, ma'am, do we have a next question?
Yes. What is the role? We have a question from Dr. Ram Kumar. He is asking about what is the role of sildenafil in IUI cycle?
To increase uterine vascularity, madam. In case of endometrium, PI is more than uterine PI is more than 3.2. Then you have to give sildenafil to increase the vascularity, to decrease the resistance. Uterine PI.
Okay.
What dose do you give it and how do you give it?
25 milligrams PI given.
Oral.
Vaginal.
Vaginally, yes.
Oral they can't tolerate, madam.
Yes, yes.
Severe headache and all.
Vaginal is the preferred route, yes.
Now there's a question from Dr. Bhagyalakshmi. There's no response until day 10 and we've been using oral ovulagens. Now on day 10, can we add gonadotropin?
Dr. Anita N, would you like to answer this?
In such cases, we can see the endometrium and the estradiol levels. If the estradiol level is too low and the endometrium is not, the thickness is not there, then we know that the patient is not having any estrogen, for the follicular development is not occurred. In such conditions, then we can add gonadotropins.
Otherwise, you can give other oral ovulagens also, madam. Sometimes letrozole they can't recruit. 9th day also we can give clomiphene. Then follicular recruitment, pregnancy also.
We can definitely add gonadotropins on day 10, ma'am. Even by just monitoring through ultrasound when there's no follicular growth or the ET is thin. Other than adding oral ovulagens, we can start with gonadotropins on day 10.
Okay.
Now this is the last question. In obese PCOS, what would be your dosage of choice?
Dr. Prashanti, would you like to answer?
Yes, ma'am. In obese
Madam, increasing the dose, madam. In obese PCOS also you have to increase the dose around 150 international units. And one more thing, the gonadotropin you have to give IM, madam, not subcutaneous. For some patients, the route of administration also differs, it seems, for follicular growth, madam. Subcutaneous, it is inadequate. The route of administration also sometimes matters, it seems, in obese PCOS. Ideal is reduce the weight, BMI, weight reduction.
Weight reduction should always be the first step, especially
in
morbidly obese patients where the BMI is above 40. It's not even worthwhile getting them pregnant in that state. The chances of pregnancy will be lower. The chances of comorbidities during pregnancy will be higher. So even
the gonadotropin action also, we need to give higher doses of gonadotropins. It's always better before starting IUI or IVF. First, it's always better the patient comes to an ideal, at least they reduce from, if their BMI is very high, at least they have to reduce 5% their weight. That would give a better result. Whatever, even if we give ovulagens or gonadotropins, we do an IUI or IVF. Lifestyle modification is one of the very important aspect which we need to counsel the
Diet
patient.
to physical activity, lifestyle modification before starting treatment. These are the ideal things. Aerobic exercises.
We should ideally send them with a proper plan on what kind of exercise they require. With women with PCOS, at least 5 days a week, 30 to 45 minutes moderate exercise, even walk, and also some kind of guidance on the diet that they are following. Because if you just tell them lose weight and come back, they are not going to lose weight and come back. It's in any case difficult for women with PCOS to lose it. Plus, they need that little bit of push or motivation. Often I tell the husband and wife to start going on walks together or to follow a diet plan together, because when they motivate each other, it's more likely to work. So yes, with PCOS, that should always be one of the first steps. Of course, if this is a woman with a lower ovarian reserve, then we can't spend too much time waiting for her to lose weight. And that much time she'll lose whatever reserve she has as well. Are there any further questions, ma'am, from the audience?
I think better to close the session now, because it was a wonderful session, Dr. Sulba, and thank you for moderating this. And I thank all the wonderful panelists. Now over to Dr. Sirisha. She will deliver the vote of thanks.
Thank you.
Sir, thanks to Dr. Ketur sir and Dr. Silva ma'am for their excellent moderation, and special thanks to all the young dynamic panelists for the wonderful interaction, and thanks to MQR team, Dr. Amit and Komal for their technical support, and thanks to all the delegates for their participation. Thank you one and all.
Thank you. Ma'am, Dr. Padmaja madam want to tell about Dr. Bahadur guidelines something. Madam texted me.
Can Dr. Komal, can you just add on Dr. Padmaja ma'am?
Okay. Just I have promoted her to panelist.
Yeah.
Now, Dr. Padmaja, you can unmute yourself and Dr. Padmaja, you can unmute yourself and you can turn on your videos. I believe she is.
No, she's muted because she wanted to give the closing remarks.
Okay.
Shilpa madam, for lean PCOS, if you go for LOD or for obese PCOS, you can go for LOD. Madam. For in our case scenario, for lean PCOS only, we are doing LOD as a last resort. For obese PCOS, only weight reduction and
Yes. Although lean PCOS patients can also have insulin resistance. So although metformin is recommended for PCOS with BMI above 25, but it also helps lean PCOS women. If you see the classical signs and symptoms of hyperandrogenism, it can be added for them as well.
Madam, we are waiting for you. Most of them you said that will be, so we're just waiting.
So I can see that doctors are asking for the recording of this webinar. So the recording of this webinar will be available on our YouTube channel, either Virtual Academy. I'll share the link with the doctor.
Dr.
And then you
Padmaja
can
madam is not available. She has some emergencies, but she left. So shall we close the session?
thank you. Madam.
Sure.
Thank you so much.
Sure,
ma'am.
doctor.
Giving me
Thank
the
you so much, Dr. Sudha.
Thank you, Sudha madam, Sirisha madam for giving me the opportunity. Thank you, Sudha madam also.
Thank you so much.
Thank you, Dr.
Sudha, you were really excellent.
Thank you, Dr. Silva. So, Dr. Sudha, with your permission, I would just like to close the session with one video for one of our brand. I would just play the video.
Dydrofem. Dydrofem is bioequivalent to Innovator at 25% lower cost. It is made using complex photon bombardment and purification process. Dydrofem's structure is exactly like the reference dydrogesterone structure. This brand is brought to you by Dr. Mukund Gurjar, rated as one of the top 75 scientists in India by CSIR. Dydrofem is brought to you by Encure, India's #1 company in women's health, most trusted by gynecologists. It is for patients with recurrent pregnancy loss, history of miscarriage, and defective luteal phase.
I believe I'm having some connectivity issue. So, not an issue, doctor. Thank you so much, Dr. Sudha. Thank you, doctor. Thank you so much, Dr. Sirisha. I'll just close the session now. I'll end the meeting with your permission. Thank you.
Thank you, Dr. Sudha, Dr. Sirisha. Sulva ma'am, the slides were really excellent.
Thank you so much, ma'am. I'm so glad you liked them. Thank you, everyone.
Thank you, Shilpa ma'am. It was a good discussion. We thoroughly enjoyed it.
Thank you, Dr. Vignata.
Thank you, Dr.
You're on mute.
Sure.
Thank you, Shilpa madam.
Dr. Sulba, you have a mesmerizing chant on everybody. You mesmerize everybody with your slides, the way you spoke, the way you moderated.
Nice
You're
presentations,
too
madam.
kind with your words, madam. Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Thank you, Sirisha ma'am.
You can close the session.
I'll end it.